So it is the right knowledge along with the right action which helps in controlling these.
Yeah.
And people have to set examples for others to follow.
Here I would like to bring in Dr. Surendra Atri sir. Are you here, Dr. Surendra Atri sir?
Yes, Deepak.
Sir, you have been our COVID coordinator at Medical College Kathua, and you have been doing human service there. And I had seen you running here and there too at that moment when COVID has just started, and we had to stop everyone at Lakhanpur. I just wanted you to share your experiences about that time and how to go ahead.
So at that time when the lockdown started, the first challenge with us was to separate the COVID and non-COVID areas. We should have COVID triage, ILI or respiratory tract medicine OPDs in a separate setting, and ensure that COVID and non-COVID areas of the hospital are separate. Then we had to do screening so that the patients or attendants which are entering our non-COVID areas, they should be screened for ILI or fever-like symptoms. So that was big challenge. At that time, the general population was not aware. Like now, most of the people know that we have to use sanitizer, we have to use mask, we have to maintain social distancing. So to begin with, especially in early March and late March and in early April, this was big challenge. So that was my experience, like the sampling area, COVID triage, the COVID OPD, they have to be separate. Then definitely isolation ward and quarantine ward, they have to be separate from the COVID areas of the hospital. Deepak?
Yes, sir. Yes, sir. Yes, sir. Ravinder, is everything okay now? Are you in control? Ravinder and Sunidhi, please next slide.
Okay, sir.
So this is where we are. Everybody is confused what to do next and all that stuff. Next, please. Next, please. Sunidhi, next. This I had already discussed. Next, please. Next. So, how we can control basically disease is by research, and we have kept this K factor as knowledge and karma. Karma for a doctor and a scientist is research. So I would like to bring in Dr. Rakesh Kapoor, sir. Sir, am I audible to you, sir? Are you here?
Yeah, Deepak, I can hear you.
Sir, I wanted to know from you about how research can help us in fighting this pandemic. And at the same time, another thing I wanted to know from you, as we were discussing, you were not here, about hypofractionation and other things. What is your take on it? How can we change our protocols? Please, sir.
So, Deepak, at the outset, initially when we started off with the pandemic, as all the healthcare workers, they were having problem in deciding how to cope up with it. But gradually with learning experience world over, now we have at least few strategies which have been made by most of the international consensus committees, and in India also most of us, those who are seeing number of patients, we have formulated some guidelines for that. The most important thing is that definitely research is going to help us at various areas, that you must be seeing multiple publications coming on the pandemic and management of cancer in the pandemic. Important. So we have to identify those subgroups and try to find out that which subgroup and which type of patient in that subgroup requires immediate treatment, where we can delay the treatment, and this all is dependent on the consensus based. The results or the outcomes right now we can't say, but at the end of the pandemic, once everything is over and we have the initial publications with us, sometime later on, maybe after a year's time, we will have to really evaluate that what was the impact of bringing in these changes which we have adapted in either in treating head and neck malignancies, which are the most difficult component in the COVID-19 because of the oropharyngeal and the nasal mucosa being the host site for having the COVID virus. And rest of the malignancies where we have either adopted hypofractionated approaches or we have delayed the treatment, keeping in mind that they are low risk cancers as compared to the high risk where immediate need for radiotherapy or chemotherapy was there. Second question which you have said regarding the hypofractionation, we were already knowing in certain malignancies hypofractionation has been an answer and the results were not compromised. Like let's say for example carcinoma breast. Initially we were adopting a protocol of giving either a 40 gray 16 fractions or 35 in 15 in PGI, and later on the same was reciprocated now after the start A and start B trials. But in between there was an era when people were giving 50 gray 25 fractions in 5 weeks. So I think somebody's
Please
yeah.
mute.
So
Mute. Please everybody mute. Sunidhi, mute everybody.
so
Yes, sir.
now we have now revisited that and we have gone to the hypofractionated protocol as a radical treatment I am talking of. For example, in breast, so 14, 16 has we know that it is not going to compromise the treatment, so it is used more oftenly now. And in the pandemic area, there is in the this COVID-19 situation, there is no harm in using that protocol. The second component is where we are using the you can say actually the radical treatment is required in head and neck malignancies. So we have identified those. Dr. De Cruz is here. He has already highlighted there the role of the surgeons. And we also have identified which are the areas where it is important to give the treatment, whether in the radical options or in the post-operative adjuvant options. In the radical options, like in for larynx, we know that we should not delay the treatment. So we have hypofractionated protocols there also without compromising on the local controls as well as the overall survivals. However, regarding the complication rates, I'll still be skeptical in certain areas that whether the same hypofractionated schedules with 3 gray or 3.2 gray per fraction are going to give you the same toxicity, or is it going to be increased? I am talking of late term toxicity only. But in breast, prostate, I think the difference is not going to be much and they are very well reciprocated. So both the things are there.
Oh, thank
Deepak,
you, sir.
Can you
Yeah,
hear
yeah,
me?
sir. Yes, sir.
Am
Yes,
I
sir.
clear the
Clear,
answer? Yeah.
crystal clear, sir.
Okay.
So, am I audible?
Yeah, I can hear you.
Yeah. Dr. Sham Srivastav, sir, are you here? Dr. Srivastav, sir, have you joined? So I think he has not joined. I'll request Dr. Rahul Sharma to please have his take on this hypofractionation and other things, changing schedules. And one question I want to ask Dr. Rahul is, in Medical College Jammu, how we are following COVID testing protocol as far as chemotherapy goes? Dr. Rahul?
Yes.
Dr. Rahul Sharma, are you here?
Yes, I am here. Actually, we
Regarding
have
chemotherapy,
got
what protocols are being followed?
yes.
Because we have not
So
joined by the medical oncologist because of technical age. Can you please take on this question?
yes, we have rapid antigen test kits available within our department, and we are doing rapid antigen testing in all patients before each chemotherapy cycle.
Okay.
And second, your question was about uh, any modifications in the chemotherapy protocols. Personally, I have been using more of the oral drugs now. Wherever I can, I have substituted the with capecitabine, for example, 5-FU infusions have been substituted with capecitabine tablets. And even for some stage 4 cancers, we have been preferring the oral regimes, and sometimes also the weekly schedules of intravenous chemotherapy have been replaced with 3 weekly schedules. And in certain cases where the benefit of chemotherapy is doubtful, we have advised patients regarding best supportive care only at home. And the other thing is that we
Sir, please unmute. Rahul sir, please unmute.
And regarding the hypofractionation in breast cancer, we have already been following this 40 gray 15 fraction schedule for the past about 4-5 years. But during this pandemic, in head and neck cancer cases, especially in the elderly patients, I have been following the split course accelerated hypofractionation radiation, where we give 30 gray 10 fractions initially. Then we split the course for about 2 weeks and then give another 30 gray 10 fraction with spine sparing. This we have been following, and in many of the patients who needed concurrent chemoradiation, uh, for example, in CA nasopharynx, we have started them on the neoadjuvant chemotherapy protocol, and we have postponed radiotherapy for a few months initially, and some more modifications we have done in certain cancers. For example, in glioblastoma multiforme, instead of giving them the regular schedule, we are now giving them 40 gray in 15 fractions. These schedules we are following in some of the elderly patients.
Okay. So, Dr. Srivastav sir, have you joined? So, are we having our administrators? 2 administrators were there. Dr. Yashpal sir or Dr. Mr. Amit Sharma ji? Sunidhi, next slide, please.
Yes. Yeah, I am here, Deepak.
Ji sir. Sunidhi, next slide. Sunidhi, next slide. So, sir, I would like to ask you that during this, you are administrator. First, let me introduce you to the panel and the participants. You are administrator of the Government Medical College Jammu, the most prestigious institute of our region, our province. I would love to have you in this panel, and I like to ask you how you are coping with this pandemic, and what is your take on optimization of services?
You see, Deepak, first of all, thanks for inviting me in Pravecon and this discussion in which we can share our perspective. Although we are not technically into the things like you all are experts of the field and domain, but yes, in general, we are doing the best possible we can to actually fight it out, especially regarding optimization of services you are saying. So we have come up with certain kind of rosters. We are trying to actually fix up the responsibility of respective head of departments of different you see faculties. Like yours is a very, very specialized and a very I would say a life-threatening kind of disease in which people go in a state of panic. So the topic is quite apt, like 2 C's, that is cancer and COVID go side by side, and with knowledge and karma. So the topic seems quite apt to actually understand what it is all about. So regarding optimization of services, we are doing the best possible like we can. We have seen that where proper staffing is required, we are actually going in for provisioning of some additional equipment, like provisioning of ventilators, provisioning of you see this rapid antigen testing kits to different departments. As Dr. Rahul was just sharing, that we have a separate protocol that is an oncology department of a GMC. They are taking care of those things exclusively with their patients, like when they have to go for conducting different procedures or different therapies upon their respective patients, that is chemotherapy, they would utilize those things. So similarly, like we have actually tried to set up a control center. Government has taken a very serious lead in the UT. So what we have gone for is the creation of a 24/7 helpline control center, which has direct access for the patients, for the doctors, for the administrators, for everybody. Actually, one can see through the things. So any moment, any time, if there is any kind of lapse, it's, and mind you, this is a center not only for the government medical college but for the whole of the province. That is, any place, any mishappening, any kind of requirement, any services shortfall, so we will, the control center comes into action promptly, and immediate steps are taken, remedial measures are taken, some activities are done so that the shortfall is filled up. So that is one part regarding doing the best possible to optimize the services, and rest, like HR management is very important. These days I have felt like we have gone for more additional recruitment of exclusive COVID related staffing. Like we have gone in for almost I would say around 125 staff nurses. Exclusively we are deputing them to COVID wards, and then we are getting some nursing orderlies also. That means the HR is very, very important part. We cannot ignore it. So we are trying to actually optimize the services in terms of human power, then in terms of provisioning of kits, uh, doing all kinds of testing. Like in certain cases, RT-PCR is a prerequisite and it's a must. Like you can't go in for any procedure, anything, be it in any kind of OT. You know, this is the protocol everywhere, I am sure, being followed. So wherever, whichever service is required, and then I want to share that COVID has basically, this year again, this Krabicon is always a gala affair. So this shows that how COVID has brought about systemic changes, the way we have been operating things, the way we have been doing things. So we have actually done a complete overhauling in the way services are being provided. Like OPD timings are changed. We are going in for online. We are going in for tele consultation. Our experts, our doctors, our professors, our HODs, the whole teams are available, teleconferencing 24/7. And recently I have gone in for what actually has happened in AIMS. We are actually very actively pursuing and chasing a project of giving totally online OPD and all these services in GMC and all its associated hospitals. And we are almost at the final stages. We have got some expression of interest also. We'll be discussing amongst our team. So I mean to say that has really helped actually in systemic improvement, also in optimization of services. It has brought a
Thank you, sir.
natural change, natural
Sir, we
positive
are
change.
running short of time, so I would like to wrap up, and I'll request Dr. Pankaj Chaudhary to say last few words, sir. With that, we will wrap up. Dr. Pankaj Chaudhary, sir.
Yes, Deepak, thank you very much for having our region of North Bengal and Sikkim on Krabicon. Very different perspective from our side. Deepak, am I audible? Can you hear me? Deepak, can you hear me? I don't know if I'm audible. So Dr. Raj said, okay. Yes, sir. So I think our region is very inaccessible places, as everybody knows, the Darjeeling and Sikkim. So the problem was, we started a teleconsult clinic so that people can, as been told by other people, at least get the consultation and the right. Who has to come, who has not to come. Follow-ups can be wait for a little while later, and the rest of the things which have been spelled out. And we started in a big way cancer awareness and basic oncology. CABO we are saying, so that various groups become more aware about the real realities which is lacking, and people don't present in a very bad shape, so they weigh out the risk versus the benefit, COVID versus cancer. So I think thank you very much for listening to me. Thank you, Deepak.
Thank you, sir. Thank you. Sunidhi, next slide, please. So next slide. Next. Thank you very much. Thanks to my esteemed panelist for joining, and I'll request coordinator Shalu to take over. Dr. Raj sir, please say.
Thank you, Dr. Deepak. Thank you so much.
I'm here.
Ji sir. Sir, please say a few words before we hand it over to coordinator.
Well, I think this has been an excellent discussion. We all are changing our practices depending on the COVID situation. As we are changing, we are keeping on changing our practices. radiation oncologist and cancer, as Dr. Anil Duprus told, the cancer we can wait, like early thyroid cancer, early prostate can wait. But to tell the truth, majority cancer need to be treated. And in radiation surgery, probably hardly anything can be done. They have to be operated with cancer, with thyroid cancer, early prostate PP, and chemotherapy, as Dr. Rahul told, they have to be treated. And probably, adding oral instead of intravenous. And in radiotherapy, we have an advantage of hypofractionation. So that's a big advantage. So we should keep on changing our practices as the COVID situation, emerges. Thank you very much.
Thank you very much, sir. Thank you very much. Over to coordinator and Sunidhi. Sunidhi, are you here, Sunidhi?
Yes, sir. Yes, sir. I'm here, sir.
Please hand it over to coordinator for carrying on further. And I welcome Abhishek Shankar, Dr. Gilsu Prasico, and others who have joined lately.
Okay,
thank you, Dr. Rahul, and namaste to everybody.
Thank you.
Dr. Pallavi.
Okay, thank you, sir. We had a wonderful panel discussion there. Now, good evening, everyone. I welcome you all on day 2nd of the 8th chapter of Cravicon and 2nd chapter of Tele-ONCOTHON. Now we proceed further. I would like to invite Dr. Rajesh Vashisht from Batinda, Dr. G.V. Giri from Bangalore, and Dr. S.N. Senapati for Cuttack to chair this session. And the speaker is Dr. Abhishek Shankar from Delhi. Sir is an assistant professor, Department of Radiation Oncology, Lady Hardinge Medical College and SSK Hospital. He is Directorate Journal of Health Services, Ministry of Health and Family Welfare, Delhi, India. Sir is also editor-in-chief of Asian Pacific Journal of Cancer Care, and he is founder and organizing secretary updates in oncology and educational series. We are honored to have you here, sir. Over to you, sir. Sir is speaking on the topic cancer overshadowed by COVID-19.
Am I audible to all of you?
Yes, you are.
Yes, yes.
So I can't share the screen. I can't share the screen, so from here.
So just a second, I'm just
you
a second.
Please
sir.
enable me to share the screen.
Sure. Sir, now you can share, sir. Just try.
Okay. So topic of my presentation is cancer overshadowed by COVID-19. And first of all, respected Raj sir and other senior professor here. And I think this is, everyone knows what we are talking about, and everybody will feel it, that really cancer care delivery system has really hit by COVID-19 in a greater extent when you get so many calls each and every day, how to help your patient, and sometimes you yourself is so helpless that you are unable to do anything in due to various factors. So I have nothing disclosed for this presentation. So coming to the coronavirus disease, everybody knows too much, and without the coronavirus disease, something which is a truth, something which is the antibody, nothing is effective. There are so much of warning about the steroid, and many of the discussion that we are using a steroid like here and there in mild cases with only symptoms of fever. So the biggest hope for us is vaccine, which is under trial. India is also conducting the trial. Another is the Oxford vaccine trial, which is supported by the AstraZeneca. Another vaccine is from the Pfizer. So only hope for everybody is the vaccine. Probably we will get it soon, and Russia has already started giving to the people, which is Sputnik 1. So whatever we have, this is the personal protective equipments which will save us from the COVID-19. So why everybody is talking about COVID-19? Is it the only problem that we have to solve as a country? And in India, the answer will be no. Because if you see the chart, you see the number of mortality every year from the communicable diseases, abortion, HIV, on smoking, because cigarette smoke, due to the tobacco, alcohol, you won't find still the number of death in India is 1 lakh of coronavirus disease is important, but other diseases you can't really tell your other patient to just wait till this pandemic is over. We just waited during the lockdown, but now the situation has come because this is costing life to the people. And coming to the cancer care, we know, and Ratsa will agree with me, that 15 lakh new cancer patient is coming. If you see, every patient requires 3 to 12 months for the treatment, depending upon their type of cancer. So during this pandemic, somebody has stop their radiotherapy, chemotherapy, somebody has to start. Now you can understand this, all people for last 1 year duration, they will not get a fair chance to cure the disease. So now you can understand how COVID-19 has affected our whole system. Coming to cancer care, this genesis of this paper in March, I was talking to my colleague in US. Then he was talking how coronavirus disease has affected the life in USA. Then thought if it comes to India, and we were trying to impose the lockdown period. So we conceptualized this thing that if the lockdown will happen, how it will affect the cancer care delivery system, and what will be the challenges, and what cancer care provider, cancer patients should know about how to prevent the spread. So this we just published in early March, and this has been cited almost 80 times. Citation is in last 4.5 months. So this was one of the early paper on the cancer. This was the second paper we published in the hemato-oncology care, because managing the hematological malignancy is a very resource-intensive task, where you require many other things to take care of this thing, because you need blood products, you need blood products, and other things. And coming to the lung cancer,
He is the only one to take care of his son presently. I am thankful to him that he has come to speak. Please bear with him.
I'm so sorry. Coming to the lung cancer
it's
management
okay.
challenges. It's another cancer which is very difficult to cure. And most of the cancer in India present in the later stages, advanced stages. And we all know that how difficult it is to manage lung cancer, because it presents very in the advanced stages. So if you see the initial data coming to the oncology, how viewpoints has become very important. It was not at all important as far the evidence-based science was concerned. And in cancer, you need to rely on the data which was coming from the randomized control trial. So we thought, if we just reviewed the literature, we found that most of the people who are writing for the cancer care, how this has affected. So viewpoints in oncology, whatever Chinese people have written, what is the people in Brazil has written, it really helps us to modulate our cancer care delivery. And it worked, because there was no such data. And if you just conduct the randomized control trial, it takes time to mature the data, and then when the data will come, it will take so much time. So viewpoints very, very important during this pandemic, and it's whole of the world. So we found it has a great effect on the cancer care delivery. And coming to India, it's figures very, very bad, and most of the people are in anxiety, in fear, in trouble. We are unable to help them at the right point. To the cancer research, which has really blown out, the pandemic is over, which is, they seems it's very difficult to go ahead with that, because it will require more funding. The outcome which was expected, and it would have helped the people in the longer run, now they can't expect the same outcome in view of the patient refusal. The patient is not coming, recruitment is slow, and disease progression has already happened, because in the lockdown, because of there was no communication on the road, on the flight was closed. So it all affected the cancer patient outcome and cancer research. The cancer immunotherapy is a new thing. and probably it is now coming as a future of cancer therapy worldwide. So many of the patients were using cancer immunotherapy, and now people say that yes, you should not delay any kind of treatment for the cancer, because cancer itself is an emergency situation and you must try to get the treatment. So cancer immunotherapy, immunotherapy during the COVID time, where you can delay, where you have to start it. Oncology nursing is another area which is very important for the cancer care, because you are most almost completely block the patient who are in follow-up. We have always said that please don't come, so that you can prevent the transmission. So cancer care providers, now we have set to the strict triage policy. Every hospital or cancer unit has the strict triage, and they just decide which patient to take it. Testing of the symptomatic patient is now almost a routine, and report to the authority and everybody is using the PPE at the level of care, and they are maintaining the hygiene. Now in few parts of the world, now they have started doing the COVID dedicated cancer hospital they are making, because they have realized that this COVID-19 is going to be with us for longer. So now cancer care should not be harmed. So they have started placing in some part of the China, they have making COVID dedicated cancer hospitals. So anybody who is COVID positive, they can go, but they should not withhold their cancer treatment. So cancer care in post-pandemic care is also going to be horrible. And I'm not sure that whether we are ready to accept this post-pandemic shock or not. So there will be increased load of patient in cancer care facility, although we are seeing a surge now at the moment we are getting towards the normal, and there will be a delay in completion of the ongoing trials, and there is a big question mark on the future of those trials, and bad outcome for the patient in view of delay. And we always say that cancer patient get first chance to get it cured, and this first chance is the best chance, and they're already missed it completely. So we are very skeptical about the outcome as far as the cancer care is concerned. And increased treatment cost will enable many of the cancer patients whether they will continue with the treatment or they have already used their resources, so they won't be able to do that. Increased cancer research cost is another issue. So we need to work together. I know it's a difficult time, and we have worked in collaboration. This pandemic has really made us realize that how to work in collaboration and how to learn from other mistake, another working where they've seen a very small changes where it has really given a good boost to the cancer patient. We have adopting it. So we need to work in collaboration, because illness is isolation and the crucial letter in wellness are we. So we are healthy community, and health communities has really done so much of sacrifice for this cancer COVID-19. So we have hope, and those with hope have everything. So we have to be hopeful, and we have to keep working towards the welfare of our cancer patient. Thank you.
Thank you, sir, for making us more wiser on the topic. And our next lecture, for our next lecture, I would like to invite Dr. Rajesh Vashisht from Batinda, Dr. G.V. Giri from Bangalore, and Dr. S.N. Senapati from Cuttack as chairpersons. I welcome you all, sir. And the topic is preventive oncology taking a back seat. And once again, the speaker is Dr. Abhishek Shankar, sir, from Delhi. Over to you, sir.
Over to Abhishek or chairpersons?
Sir, पहले chairperson ही बोल लीजिए.
Okay, Abhishek, continue.
So thank you. I think if I talk about the preventive oncology,
please make it fast. We were late because of technical hitch, and some international speakers are there, so we have to show them that India is on time.
You
Okay,
don't
okay,
care
go
about
ahead.
the national speaker, sir.
I want 5-6 minutes cushion for me. Please, you are
Okay,
my
sir.
friend.
So if I talk about, I will try to finish it in 6-7 minutes, sir. I will be
Thank you
fast
very much.
so that I can help. I can make a good reputation for our country.
Thank you.
So if I talk about the preventive oncology, it's my honor to speak in front of Dr. Rath, who has done maximum work as far as the cancer control and prevention is concerned, as far as India is concerned. If you see any guideline which is coming to the framework for the country, outside collaboration, I think he is the one person who has really pushed this cancer control and prevention forward. Otherwise, this has been science for the social respect and the people who are really aiming for Padam Shri and the Padam Bhushan in their life. So it has been restricted to, it is all the very non-glamorous fit, and that nobody and all, I just want to tell that already preventive oncology in the backseat, and during this pandemic, it is, has gone, further backward. So it is most important to raise your voice against the most important aspects of cancer care, which is preventive oncology, which is now having a wider domain, which was, sometimes before, because now many things are pouring in as far as the preventive oncology is concerned. So, this is very important. Now we have debated, and, we have debated with the agencies that India is in which state of, transmission. Still, nobody is accepting that we have, reached to the local transmission mode where people are infected and you are not knowing about the social, the contagion, which is stage 3. So this is the principle of preventive oncology. In other part of the oncology, it is better you can have an individual oriented approach, and you can leave other socio-cultural determinants, which, is the major reason for the disease to happen. And if you want to really get rid of the disease, if you want to prevent that, you need to be well aware about the socio-cultural determinants of health, and you need to work on that. What is missing now is the lack of attention on the socio-cultural determinants through our own individual oriented approach. You can also tell it is a selfish approach, because when we are sick, we can go to the hospital, we can help our parents to get the treatment. But when it comes to community, we are hardly worried about this thing. So when you talk about the community or population-based approaches, this is the only one way to tackle socio-cultural determinants. And when you want the prevention for cancer, then only you can have the concentrated and sustained social policy, and we can have social justice as far as the cancer care is concerned. Why prevention is key to success? Because the most common cancer types, we are well aware that what is the risk factor. Coming to the lung, we know it's smoking, mouth cancer, it's like use of different form of tobacco. Cervical cancer, it is by the human papilloma virus, and GI cancer, it is because the food habits, nutrition. So understanding this point, you can well aware that these all things can be easily prevented, because you know what is the reason of cancer to happen. If you eliminate that cause, you will get a great success. Like, people can talk about big things like immunotherapy. There are data that if you get what kind of benefit you get with the immunotherapy, it's by 12 months versus 16 months. And there are so many data, or US Surgeon General report, that if you just restrict your patient on consuming tobacco, you see a very good overall survival. There is a difference of this time. So, but our focus is just giving immunotherapy, but we don't want to focus on the preventive strategy which can help patient in the longer run. That's what I told. This is the non-glamorous area. You need to work hard, because you can understand yourself, but if you have to understand the other people, it takes more time. So nobody wants to give that time, because as a doctor, you get so many, responsibility related to your patient. So awareness is the need of the hour, because it's the driving force for cancer outcome in India. And you need to make people aware in real sense. You don't need to, because there is a difference between aware and the pseudo-aware. I give you a simple example. People are not afraid of smoking 40 cigarettes a day, but they are fighting with the tea seller when they are given tea in the plastic cups, because they feel that it is a cause of cancer. So we are just having a life of the convenience. Medical checkup is not a priority. we don't mind, talking on phone for 10 hours a day, but we always become the, RTI activist when you see that in your nearby, there is a, this radiation source or something, installed for the, mobile tower. So you don't like it. So we need to prioritize health, and especially cancer health. So what is important? You need to make people aware about cancer, and in this COVID-19 era, you need to make them well aware about COVID-19 too, because both the things are important nowadays. You can't speak about cancer and you can't, miss about telling COVID-19, because these two things are interrelated. If they don't take the proper precaution, which is an important form of prevention, it can lead to disaster. Diet, immunity, and COVID-19, it is always said that obesity is related to more than 12 types of cancer. And the people who are, obese, they have it's a poor immune function or immune response. So you can well understand the COVID-19 has so much to do with the immunity. So these things are correlated. If you just work on one factor, you ultimately benefiting the people with the other disease, which is COVID-19. Prioritize healthy foods, tobacco control and cessation, I will discuss in detail. Early detection through screening, because most of the in India comes in the advanced stages. Few cancers you can really wait for the benefit. Otherwise, if they diagnose as usual, nobody can make them survive. So there is also important in the continuum of care. If you diagnose somebody through screening on time, this is your responsibility, and that is an ethical concern to make sure that they complete the treatment and they are always referred to the right place for the treatment. So these are the breast cancer. Breast cancer standard is mammography, which is done from 45 to 54. So if you just want to delay it, you can delay it. But now how much delay? You can afford it, because this pandemic is already 8 months. If you just tell somebody that says you can delay it for, and if it is continue for another 1 year, 2 years, this is the only way where breast cancer you give, any female a fairly good chance to detect in early stage, where they can, get the treatment, don't have to go for the complete, removal of the breast. They can maintain cosmesis, the treatment cost is less. Cervical cancer is another cancer where we have good prognosis, but yes, if you detect it early. So pap smear and HPV DNA, and it is every 5 years. So people can wait because it's a long duration. Oral cancer, oral visual examination in the high-risk patients who are consuming tobacco, and it is, proven on the Sankar Narayan study. If you just screen the high-risk patient with the oral visual examination, you can really save life of a patient. Lung cancer is the most important, and in India, lung cancer incidence is going high, and it will be a most important public health issue. And now with the data from the National Lung Screening Trial and the Nelson study, it is important to reduce the mortality from the lung cancer if you practice the low-dose CT scan as a screening modality from the lung cancer. This is the previous data where it was 20 pack years per day. Now in July 2020, US Preventive Services Task Force has now it reduced to 20 pack years. And initially they used to screen patient from 55 to 80, and the age bar has also been reduced to 50 years. Colorectal is another cancer. So the whole exercise is that screening gives you a fairly good chance to detect it early, and it helps you to, in some area, to longevity and the other decrease cost, decrease multimodality treatment facilities. So in this time where everything has been taken up by the COVID-19, probably we must start looking at the cancer prevention to give everybody fairly a good chance to prevent themselves from cancer. So awareness through all possible tools is the best way, to reach to people. And at this point of time also, we need to make people aware about the alternative. So this is another, we have published another data about how socio-cultural, life is related to the coronavirus on the cancer patient, and it has a huge economic impact. You can, just access it online. Another thing we have written, as far as we in India, if you talk about prevention, and if you don't talk about complementary and alternative medicine, it will not be a good idea. We publish the, summarize the data from all over the world, how they are using the CAM, which is complementary and alternative medicine, in prevention of COVID-19. Gujarat government has really, given a good amount of thing that it helps to prevent it, and so, tobacco smoking and risk of novel coronavirus infection is another publication we did during this corona time. And we have nicely summarized that how tobacco smoking is related to the lung health. And we all know that tobacco smoking is a risk factor for COVID-19. And COVID-19 is primarily a lung disease, although it's also affect the blood vessels of the lung and other important organs. And it affects more severely to the smokers. So if you quit smoking, and we just try to make a campaign during this corona time, maybe online, so that we can really help people to quit smoking, because it's not only help to prevent severe form of infection of coronavirus disease, it also saves you from the COPD and the lung cancer. So probably the short-term intervention should have a long-term sustainability. We don't want people to save themselves from the coronavirus disease and they should die from the lung cancer. So probably our intervention should be directed towards the short-term intervention with long-term sustainability. And although in two of the Chinese study has already shown that the people who are admitted in the, with the severe form of coronavirus disease, they were smokers and they, did, poorly during the course of treatment. So again, I have the same question: is this coronavirus disease so important that we should halt all other services, which is also important? And somebody will analyze after this pandemic is over, about the known COVID mortality. Probably you will find that people have died from the, other diseases much more higher than what we have seen in the coronavirus disease. So disease is important. We are having precaution. We are a provider. We should not stop, thinking about every aspect of the cancer care, because it is interrelated, and one intervention can really help you to, gain in the next intervention. So it is a multidisciplinary approach, and it can help, people to really detect cancer at earlier stage. And it is the most powerful expression as far as the cancer care is concerned. Thank you very much. And we have to be optimistic in spite of all the difficulty, and we should, make this difficulty as an opportunity rather than being pessimist who always think that, every opportunity has a difficulty. Thank you.
Thank you very much, sir, for such an informative lecture. Any questions from chairpersons?
Okay, continue. As we are running late, please call Dr.
Okay, sir, for consideration. Okay, for next lecture, chairpersons are Dr. Rajesh Vashisht from Batinda, Dr. J.V. Giri from Bangalore, and Dr. S.N. Senapati from Cuttack.
Please call Dr. D'Cruz early.
Once again, sir. And the topic is rationalization of resources towards 2 Cs. And our speaker is Dr. Anil D'Cruz from Mumbai. Sir is the President-elect UICC Geneva, Switzerland, and Director Oncology Apollo, Delhi, Mumbai, and Chennai. We are honored to have you here, sir. Over to Dr. Anil.
Are my slides seen?
Yes, we are seeing.
Yes, sir.
Okay. Namaskar. Good evening. Thank you, Deepak, for giving me this opportunity again to be here. And I can see the number of people increasing, participants on the, but we'll miss your kind hospitality, as I said at the beginning of the panel discussion. It's a difficult topic to speak on. Abhishek and the panelists have already covered most of the point. I am cognizant of the fact that we are running late, and I'll try to quickly wrap up so that we have adequate time for our foreign faculty. A quick clarification, Abhishek, Deepak, I am Director Oncology. I'm still active in practice, and I practice at Delhi, Mumbai, and Chennai, but I kind of look after the administration of the entire oncology of 14 centers.
जी
So everything was good for us in the cancer community for many, many years. And then suddenly from December, COVID arrived and it changed the way the world is. We have this big mask, social distancing, getting scared to go to each other, and it impacted in a big way on cancer treatment. So our focus has been to understand the impact of COVID on cancer patients and their well-being in these unsure times. We have to balance fear of COVID versus resources of treatment and control. And we have to ensure that our organizations survive the financial impacts of the pandemic. And the UICC, we did a little study among all member organizations. We sent out a questionnaire, and you'll be surprised to know that at least 60% of organizations have taken a hit on their finances, and 3 to 5% of them will fold up.
Dr. Cruz, I'll have to interrupt. I cannot see slides, sir. I don't
Yeah.
think anyone else
Say
can
that
see your
again.
slides. We can't see your slides, Dicky.
We can see Dr. Abhishek Shankar's slide, sir. Can you please do slide share, Dr. Cruz?
I've done slide share. Then Abhishek has to.
I am seeing. Sunidhi, please check.
I think.
I am
Okay.
seeing sir slide.
I think the slides have come now.
Yeah,
Okay.
that has come.
Okay. Okay. And lastly, I was saying that many organizations have to fold up, and this is data we'll release on the 6th of October during the General Assembly of the UICC. But I can tell you that at least 2/3 of organizations have taken a severe hit on their finances, and these are all cancer organizations. I'm going to sum up what everybody has said in a very simple quote that I have made. It says there is no contraindication to cancer treatment. If the contraindication here read COVID doesn't, the cancer will kill. So it's important to realize COVID is going nowhere for the next 2 years. Cancer has been there for ages. If we get scared, we change treatment without enough scientific rationale, we're going to kill our patients. We need to balance the effect of COVID versus the outcomes of cancer and take a balanced decision for our patients. What are the impacts of COVID on cancer care? And this will be able to summarize what we need to do. For patients, they're concerned about going to their doctors, hospital for fear of contracting COVID. Many countries have restrictions in place that has made travel difficult, so they can't come for a checkup to their doctor. There are delays in treatment, both because the patient is scared, cannot reach, but more importantly, doctors are unsure how to treat the patient. And it's very apparent we all have ideas, but there's no one protocol that we will follow. And there's a higher risk of serious implications necessitating changes in treatment protocols. And this will have unknown consequences. For cancer control, screening programs are on hold in many places. But I must tell you that screening only contributes to about 10% of early detection. Strengthening our healthcare system is very important, that patients can see their doctor at early symptoms and can then be directed to cancer specialists. Cancer services and resources are diverted by governments because they have to put the resources into COVID. And this we are very, very familiar in our country. For years, there was not much money in cancer because we were tackling infectious diseases. Now it started coming into NCDs. There's shortage of medicines in many countries, and hospitals have to re-engineer their operations to protect staff, patients, and families. And we've seen it in the hospitals that we work in. Now look at the impacts of delay in treatment, and this is for everybody listening. I've only put up two or three examples, and these are examples, one from head and neck. An old paper in the Green Journal from Chen et al. 2008. There's a 16% increased risk of deaths exists for every month of delay of radiotherapy for patients with head and neck cancer. This came in 2008. our major teaching institutions, including Tata's, All India, wherever we are, have a waiting list of more than 4 weeks. And you can see the impact on outcomes on these patients, 16% increased risk of death. And as Abhishek said and others said, the recent advances do not give you an 16% increment in benefit. We should have done something before COVID came. Maybe it's going to help us. There's delay in receiving adjuvant chemotherapy for colorectal. Again, implication, hazard ratio of 1.14. And breast cancer, again, an 8% increase if you do not treat your patients with adjuvant on time. Remember, 8, 14, 16, bigger percentages than the recent advances. So we must not delay treatment of our patients. And here we come to the tiered approach. And the simplest one is the ESMO tiered approach, making patients into high priority, medium priority, and low priority. In my book, of 100 patients that we see with COVID or cancer in COVID times, there'll be only 5% of patients who will be in low priority. The majority of patients will be in medium and high priority. And sometimes it's very difficult to triage patients. There'll be a gray zone between low and medium, medium and high. And you can see doctors and multidisciplinary tumor clinics having different thoughts about the priority of the patient. But I liked a beautiful step ladder pattern that I read in Nature Reviews, May of 2020. And there are two important points on this. The priority cannot be into watertight compartments. It's a gradual increase. But please look, all the low priority are based on two things. One, if they are alternative treatments, which we have few, and the majority of palliative indications. So this is something that you need to keep in mind. Palliative could take a lower priority. Most of the ones which have eminent early mortality, like the leukemias, aggressive lymphomas, metastatic germ cell tumors, take very high priority and must be treated. And the majority of others fall in between, but wherever there's significant impact on delay, those patients must have treatment. The other important point in this article is your triaging of patients is dynamic. You cannot make one triage today and keep it for the lifetime of that patient till COVID is over 2 years. So today I may be in a high priority zone and therefore I should get my resource. But after some time, if I relapse, say a head and neck in 6 months, my priority level comes lower. So we should keep two things in mind. The intensity of the disease and our process should be dynamic. There are new normals in all we do. And though we have COVID, which is a dark cloud, all I can say is that every dark cloud has a silver lining. Because of COVID, we are forced to do new treatment protocols. And I loved when the panelists, all radiation oncologists, talked about different fractionation. Our country should have done it earlier and decreased treatment times of our patients, but maybe COVID has forced us to do it. We'll have a new normal for screening. We don't have to ape the Western and do non-ionic, low-resolution CT scan to diagnose lung cancer. Maybe we'll find something different. As I said, lung cancer and all cancers, there's a 10% increase. Maybe we might just have visual inspection of cervixes and decrease the incidence of cervical cancer. Low-cost screening for breast cancer. We don't have to send our patient to the mammogram room. Maybe just examination by health workers or the patient themselves. There'll be a bigger role of teleconsults and less hospital visits. Footfalls in our hospital will decrease because of teleconsults. And our resources then can be prioritized to patients who are at the hospital. And the most important resource to me is doctor time. So if I see 40 patients at Tata Hospital when I was there in an afternoon session, If I have 10, I can give them more time. And all of you all, hand on heart, tell me that is the most severe resource that our patients need. And many of us are not able to give them, not because we don't want to, but because of the time constraints we have. Meetings will be hybrid, and we will use digital platforms to stay connected. So some of us will go to Jammu, some of us will follow the deliberation, and probably that will result in cost saving and more people joining, because everybody cannot come to Jammu next time for the meeting. So some of us will go, some of us will follow these lovely discussions and presentations from home. And we'll have innovative modes of raising funds to help our patients. And most importantly, this new normal will result in cost savings, and this can translate to better patient care. This money can be funneled into patient care. I'm going to conclude by saying that many of us and the world is still understanding COVID. We don't know what's the right treatment. We are working towards a vaccine. We don't know what's the interaction between COVID and many, many diseases. Most of what we say is logical, and it's from our experience as a community that's dealing with cancer. So we must reach out and support each other as we learn more and more about the intersection between COVID-19 and cancer. We must share practices across the community to better deal with its impacts. So tomorrow, if Deepak or Dr. Rath has a practice, it must be made public. And I was so happy to see Abhishek publishing, because that practice can then percolate to other centers within the country. We must engage our governments to help deal with COVID-19, but at the same time emphasize that the specific needs of cancer patients cannot be neglected during these unprecedented times. And here is where people who have hold in the government, such as Dr. Rath, have to play a very, very critical role for all of us. We must share ideas on how we raise funds to be able to survive these troublesome times. But most importantly, and I want to end with this message, we must not lose focus and ensure that cancer is firmly in the minds of national governments as we seek to build back better post-COVID. And I'm very sure COVID will result in a lot of positives. Of course, they are negatives. I want it to go away, but there'll be a lot of positives. I end with a thank you. And I want to say that I take over as UICC president on the 6th of October. This is a slide I borrowed just to make that the General Assembly is there. I am the first Indian to go into the UICC as president. I'm delighted with this role. But I'll also be the first president from 1933 to take over virtually. And that distinction, no one can ever take away from me. So I need your help, your support, your blessings as I have this role over the next 2 years. Thank you, Deepak, for giving me the opportunity to speak. And thank you for all my co-panelists, delegates, and others for listening to me. Thank you very much.
Thank you, Anil. And
Pleasure is over.
congratulations to you on your new achievements. And thank you, Chairperson.
I'll please request chairs to close the session.
Thank you, Dr. DeCruz, and very nice presentation. You carry on message is very good. And we must congratulate in advance to you before taking you advance. You are, this is the pride of India. You are representing us in UIC. All the best, Dr. DeCruz.
Thank you, Rajesh. Thank you, Rajesh.
Congratulations.
Thank you. Thank you, Dr.
Dr.
DeCruz.
DeCruz, we have been behind you from day one when you are fighting for election UICC.
So now not behind me, साथ साथ कदम कदम चलेंगे, साथ में पीछे नहीं. आप हमारे साथ.
Thank you.
It was brilliant lecture.
Yeah, excellent.
Thanks. Thanks, Giri. Thanks, Dr. Senapati. Bye.
Thank you. Thank you, boss.
Thank you.
Thank you, Speaker.
Thank you,
Sir.
Chairman. Over to coordinator.
And for the second panel discussion of the evening on breast cancer management and newer advances, on expert chair, we have Dr. AFM Kamaluddin from Bangladesh. Sir is a secretary, Bangladesh Oncology Club. I welcome you, sir. And Dr. Suleiman Chaudhry, sir is former principal GMC Kathua. Welcome, sir. Our moderator for the panel discussion is Dr. Kanchan Kaur from Gurugram. Ma'am is a Director, Breast Services, Cancer Institute, Medanta, the Medicity. Panelists are Dr. Pamela Jairaj from Ludhiana, Dr. Virendra Mohan Rana from Kathua, Dr. Vikas Roshan Jammu, Dr. Sandhya Sood from Ludhiana, Dr. Rohit Lahori from Jammu, Dr. Hilal Ahmad Wani from Kathua, Dr. Paris Khanna from Jammu, Dr. Satyankar Gupta from Jammu, Dr. Manmeet Kaur from Kathua, Dr. Anshuman Mahesh Chandra from Kathua, Dr. Sandeep Jasuja from Jaipur, Dr. Sayan Paul from Hyderabad. I welcome you all. Over to Dr. Kanchan Kaur, ma'am.
Thank you, Dr. Suleiman sir. Dr. Suleiman sir for joining as chair. Thank you, Dr. Suleiman sir.
A very
And
good
over
evening.
to Kanchan.
ठीक है आपको ये ऑन करना है
Hello, am I audible?
Yes, ma'am, you are audible.
Good evening to everyone. Thank you so much for inviting me. Dr. Deepak, as always, great show, you and your team. And this is not going to be an easy task. I have a huge list of panelists on the panel. So what I'll do is, can I see all of them in one screen? Is it possible for me to? I was just wondering if only the panelists could keep their cameras on, and if everybody else turns it off, it makes it just a little bit easier for me to.
Yes, we'll do that.
Yes,
Yes,
I think that will just make
Nidhi,
things a bit
you-
easier. Yes, sir. Yeah. Okay, and is my
just a sec, Dr. Kanchan.
Yeah.
Have we, Dr. Dharamveer has joined us from Louisville?
Yes, sir. He is
Sunidhi,
there. Yes,
Dr.
sir.
Dharamveer Jain has joined?
Yes, sir.
Yes, I'm here.
Thanks, sir, for joining. He's a known medical oncologist from Louisville, Kentucky. Kanchan, please take over, Dr. Kanchan.
Yeah. So a very good evening to everyone. COVID times, tough times. I hope you're all keeping safe. And excellent presentations that we just heard on how you know, the life of doctors who are treating cancer has been made even more difficult because of you know, the dilemmas of treating cancer patients during COVID times. I'm going to be going through a few case presentations and hope to engage my panelists on what are the newer advances in breast cancer management. So I hope my presentation is visible to everyone.
Yes, ma'am. Yes, ma'am.
And so you know, breast cancer has been known for since times immemorial, and the goal centuries ago was cure. The goal now is cure, but the difference is that we've come up from 5-year survival rates of dismal 40% to 5-year survival rates in excess of 80%, all because of personalized medicine. And personalized medicine percolating into all spheres of cancer care, right from diagnosis to treatment to preventive medicine. As cancer care becomes individualized and more personalized, the changing perspectives in terms of diagnosis, the type of surgical treatment offered, and decision making
Just listen to this.
are things that I would like to bring forth during this panel discussion, and I hope we have a nice, robust discussion. Sadly, when we talk of newer advances, sadly, in our country, still the normal protocol that we see, if this is what we call a protocol, is that when a patient discovers a breast lump, they either end up having an FNAC, which even if it is cancer, suspicious, indeterminate, or inadequate, they proceed to what is an MRM. Or some patients without an FNAC will directly have a lumpectomy frozen section, which if it shows cancer goes on to MRM. Sadly, local staging and systemic staging both go for a toss. But this is what is the true picture in our country, even now in most centers. And when we come to talking about newer advances, we can't proceed further unless we have the basis of evaluation for breast here. So this is a little picture that I've picked up from Dailies and Love, and I'm sure the surgeons on the panel will recognize this about triple assessment and how important it is in breast cancer. Unless you have your basics clear, you cannot go on to newer advances. So to the surgeons on the panel who would like to take this question, and I really want to ask this, do you think that in this day and age, clinical examination, as it is, a lot of times we see that some patient complains of a lump in the breast, she calls a gynecologist or a surgeon she knows, and even without examination, she may be told to just go and have a mammogram reported normal. Would you stop at that? Do you think clinical evaluation is important? Who would like to take this?
Good evening, Dr. Kanchan. This is Paras here from Jammu.
Yeah, hi.
I'm sorry, this is like the fastest finger first, so I'm sorry for jumping onto my seniors in the...
I think I'm very glad, this is how we'll have to probably run this, because I'm finding it a bit difficult to navigate through the huge panel that I have ahead of me. So we'll play fastest finger first, please. So whoever feels they want to answer this question, kindly do that, because I really want to, get at least these basics quickly clear before we move on to newer advances.
Yeah, so I'll just jump right into this, and I will go back to a discussion which me and Dr. Deepak had about a patient, say about a week, 10 days back. And why this question is relevant, not only when I began my training maybe a decade ago, as it is now. So this was a morbidly obese patient with a lump in the upper inner quadrant. And on a cursory examination, a cursory clinical examination, I was very sure that we can proceed with probably we can offer breast conservation to this lady. Now, she already had a mammogram done outside because, as you pointed out, she was first seen by a gynecologist, advised a mammogram, and to my horror, in the mammogram, because the parameters of the mammogram were probably missed, could be because of the patient habitus or another reason, but the lump was actually sliced since the muscle was not fully visible. And that is why the mammographic assessment of the lump was incomplete. So the point you made that we cannot play hopscotch when we are evaluating patients. It has to be a clinical examination by the operating team or by the surgeon, and then moving on to maybe a mammography or any relevant imaging modality. We just can't play hopscotch and jump to a mammogram or any investigation before evaluating the patient clinically. This was a fixed lump deeply fixed with the pectoralis muscle. So in these cases, probably the surgeon will note down these findings and request to the radiologist that I am suspecting so-and-so. So the evaluation protocol can be more thorough and will not miss.
Exactly. And also just to quickly point out that for occult cancers, especially cancers like lobular carcinomas, patients with nipple discharge and rare conditions like inflammatory breast cancer, clinical examination is important, and especially in a resource poor country like India, it should be the first modality before a needle is inserted into the patient's lump and before a diagnostic excision is done. So clinical examination is the first modality. But now we've moved on, or hope to move on in my lifetime, at least in our country, from the era of palpable to the era of impalpable lesions. The technique of biopsy. I know we want to talk about advances, but I'm sorry if I'm talking about basics to start off with, because sitting in a tertiary institute, we still deal with patients who've had biopsies before having imaging, who've had excisions before having an FNAC. So I would like to ask, what technique of biopsy is correct in the Indian scenario? I'm not talking gold standard, Western standards, operative versus non-operative. Would the second surgeon on the panel like to take this question? Who do we have? Dr. Paras, do you want to go again?
Ma'am, I don't mind. Thank you so much. I think we always prefer a core biopsy. I would not like to subject any patient to...
Non-operative. So
So it's a
preferably,
non-operative
yeah.
core biopsy.
Yeah. And when we come to, I know we've had, we have discussions on how an operative will have a more diagnostic accuracy as opposed to a needle biopsy. But the drawbacks of the open obviously being that when you diagnose a malignancy on a lumpectomy, you commit the patient to a second surgical procedure, and the psychological trauma for the patient obviously is unexplainable here. So the benefits of non-operative diagnosis, I obviously won't go through all of them, but it's important to know that in a country where 80% patients are going to be presenting in stage 3 or 4, the role of NACT is extremely important, and that is why a non-operative biopsy is extremely important. Now, when we talk of non-operative biopsies, what would be your preference, FNAC or core biopsy? Dr. Jain, would you like to take this? Sorry, I know you're a medical oncologist, but in India still we do a lot of FNACs. What would you like to tell us about FNAC versus core biopsy? You're on mute, sorry.
Okay, I'm sorry. I think I should not be an authority, but I think you have already, correctly pointed out, like being in a tertiary institute in the US and probably one of the world's premier institution, for us, these things are taken for granted, unfortunately. And I have met you, I've seen you working there also in the, a tertiary institute. Definitely, I think there are significant pitfalls, but I think it also tells us or behooves on us what is I would say, training and the convenience of our breast radiologist performing, So there's a steep learning curve in this aspect,
Voice is breaking out. So just to bring forth the point.
How confidently we can do the core needle biopsies means we're talking about. So obviously we would like to have ultrasound guided core needle biopsy as a gold standard, but I think there's so many variations in the practice patterns, and we have to adapt to the local kind of situations. Here we take everything for granted, but I think you were aptly said, it has to depend with the institutional kind of availability as well as experience.
So just quickly to go through the case now, we saw a 28-year-old patient in clinic who presented with a 6-month history of a breast lump which was increasing in size. Clinically, she was found to have a large ill-defined lump which was hard. She had some skin tethering, and the clinical impression was that of a malignancy. Dr. Vikas, are you on? Can you hear me? Can I direct this question at you, Dr. Vikas? Is he on? Who is the second surgeon on the panel? Sorry. Dr. Deepak, who's the second surgeon on the panel?
Dr. Manmeet, Dr. Anshuman.
We have Dr. Lal, Dr. Anshuman, and Dr. Manmeet.
General surgeon or oncologist?
I'm talking about surgeon.
Dr. Manmeet, Dr. Anshuman, Dr. Hilal.
Okay, Doctor.
Are you there?
Dr. Kaur, let me take this question,
Yeah.
This is probably, I think, very simple and cut through case, In this is a very young lady, the stakes are very high, her expected, means remaining life expectancy is large, and if it's already with the skin tethering, which is a T4 lesions at least, should not be difficult to do a core biopsy in this patient, So definitely, and you're right, we don't want a 2-stage kind of procedure, especially in this patient. There may be, and again, the stakes are high in terms of even primary surgical management of this disease. So, and I would like to treat this patient definitely with the neoadjuvant chemotherapy,
Yeah, so going on, this patient had already undergone an FNAC outside, which was suspicious for cancer. So when this patient presented to us, obviously she had no imaging done, And we went forward and did a mammogram. Normally in a 28-year-old, we do an ultrasound first, but we did a mammogram for her, which showed this suspicious lesion in the breast, and which was again given a BIRATS 4/5. We went ahead and did the ultrasound, and for the radiologist on the panel, if there is any, what we found was not a solid, but a partly cystic irregular lump, which we thought was probably necrotic tumor tissue. And however, there were inflammatory changes around it, and we did an ultrasound guided true cut biopsy, and this came back as showing tuberculosis. And I always like to show this case as an example to stress upon the point that an FNAC is not the right test to do for patients who are presenting with lumps. Even clinically suspicious lumps can turn out to be inflammatory lumps, idiopathic granulomatous mastitis because of tuberculosis can present like this. So just to drive home the point of the importance of doing a true cut biopsy before we take it forward. So, however,
you're right, Dr. Kaur. I mean, in India, especially, like, you know, where I have also worked, like, you know, during my initial part of the training, tuberculosis of the breast should not be, like, you know, forgotten. Every breast lump definitely is not a cancer, you know. Here we take for granted it is a cancer or some other benign lesions, but in India, the diseases are so common, and you're absolutely right, you know.
Can I make a comment on this?
Yes, please.
Yeah, not only because of misdiagnosis of a disease. Yeah, pardon?
Could you introduce yourself, please?
Yeah, I'm Dr. Sayan Paul. I'm a radiation oncologist from Apollo Hospital, Hyderabad.
Yes.
Yeah, so there is another point. Like, you need to know the hormonal receptor status and heart volume status before starting your treatment, because that will dictate your future adjuvant treatment protocols. So before going to surgery or any new adjuvant treatment, we need a core biopsy, we need a hormonal status
I shall come to that.
Status. Yeah.
Yes, great, good point. I shall come to that. It's here that I just wanted to kind of reinforce how important a true cut biopsy is over an FNAC. But an FNAC would still be needed in cases where you want to do axillary lymph node sampling of suspicious systemic metastasis, and sometimes evaluation of breast lumps in young girls when you're expecting to see a fibroadenoma. So FNAC is not completely written off. And I just want to say that in a resource poor country like India, where a true cut biopsy gun costs, you know, the costs of a true cut biopsy gun are in excess of 2,500 rupees, it increases the cost. But I think it's very important for us to see the thing in the whole perspective, because this is the first and the most important test which helps to establish a proper diagnosis. So for want of a 2,500 rupees for a core biopsy gun, I don't think we should then, you know, use that as our debate to say that an FNAC is the test that should be done because a core biopsy is expensive, because in the larger scheme of things, it isn't. And core biopsy needles are easily available, and the learning curve to learn how to do a true cut biopsy is not that difficult. So just to kind of reinforce importance of true cut biopsy. So I shall quickly skip through this. Do we have a pathologist on board? No. Okay. So, doctor, so you know, once we do a core biopsy for the definite benigns and the definite cancers, we know what we have to do. But say we have a B3 or a B4 biopsy diagnosis. What should we do for that? Dr. Anshuman, would you like to take that? Dr. Anshuman?
I think Dr. Paras can take that.
Dr. Paras, would you like to take that again?
Sure, ma'am. I'm sorry, the screen is not aligned properly. Could you help me with the question again?
So the question was that for the definite benigns and the definite cancers that come on a core biopsy, we know what to do. But what if you thought it was a cancer and the discordance is that the pathology doesn't give you a definite cancer on the core biopsy? What would your next step be?
I think this question underscores the importance of going through the proper algorithm of a clinical judgment. What exactly is my clinical judgment whether I'm ready to place it at P5, P4 or P3, or I think it's a P2. And then what my radiologist means by B4 is my radiology, whether we have correlated this B4 with our radiology findings. I would not hazard to again request my pathologist to go for a guided biopsy. But in this scenario, sometimes we have to proceed, take consent for a diagnostic lumpectomy. So that would be one place where the surgical biopsy comes in.
Yes. So Dr. Paras, you very nicely explained that if there is discordance between your clinical imaging findings and a guided core biopsy, then you must look at a surgical excision or a diagnostic excision, which could either be open surgical, via guided, or even if you have the facilities of doing image-guided, vacuum-assisted biopsies, then it is a good idea to do those, but a definitive therapeutic surgery should not be undertaken because of a B3 or B4 just because you are suspecting a cancer. So that's an important point to kind of put forth. Now, when we come to, once we've got our basic triple assessment clear about need for imaging prior to doing a needle biopsy, preferably doing a core biopsy, and not buying the debate that it's expensive to do a core biopsy. Every patient deserves to have a proper diagnosis before going to the OT. When we come to newer advances, then the advances are in those of less invasive surgeries, both for the breast and the axilla, for HER2-directed therapies, gene expression testing, hormonal therapies, and so on and so forth. The list is endless. I will initially like to talk a little bit about neoadjuvant chemotherapy. Dr. Jain, are you the only medical oncologist on board, or do I have somebody else who I could invite for this question?
So myself is also there.
Dr.
From, yes, ma'am.
Yeah, excellent. So this is a 52-year-old postmenopausal patient who presented with a lump in her breast on the right side. Clinical examination showed us that she had approximately a 4-centimeter tumor, a central tumor, axillary lymph nodes were palpable. The core biopsy of the breast lump told us that it was in an invasive ductal carcinoma, along with metastasis to the axillary lymph nodes proven on an FNAC. Now, would you, as a medical oncologist, ask for ER/PR Herceptin tissue biopsy, or since the patient is operable, would you be happy for us to proceed? Would you like to give us your opinion on this, sir?
So, ma'am, this is very important issue in these patients. Like, if a patient is operable breast cancer, like stage 2, before stage 2A, before stage up to stage 2A, we can directly go for a surgery. And if patient is after stage 2B onward and want to conserve her breast, then definitely I need this ER/PR hormone and even HER2 status of the patient to start my treatment, because now we have very much good treatment available for these HER2 patients. And if patient, even in operable breast cancer patient, want to conserve the breast, then it's okay. Otherwise, if operable breast cancer patient want to go for mastectomy, then upfrontly we can go for that surgery.
Yes, thank you. So the patient was ER. Yes.
Dr. Kanchan, I just wanted to ask, what is the nodal status? Is it N1 or N2?
It is.
You said N1.
Yeah. So she's ER 8 out of 8, PR 6 out of 8, HER2 negative, is keen on breast conservation. So should we be offering her neoadjuvant chemotherapy? Dr. Pamela, would you like to take that?
Yeah, this is a little controversial, but based on the size and the axillary node being positive, I think I would suggest a neoadjuvant chemotherapy.
And if she was not keen on saving the breast and she wanted a mastectomy with node positive, ER/PR positive disease with no other systemic met, would neoadjuvant chemotherapy still be offered to her, and why?
I just wanted to clarify about this node positive. Like, why do we calling it N1? Is it only one node in the axilla, or Is it on based on clinical examination? So,
clinical and imaging. She has mobile, palpable, ipsilateral lymph nodes. Yeah.
yeah, so she goes. She goes to stage 2, so she can be offered NACT also. That's what I would say. You can ask opinion from the medical oncologist.
Yeah. So in a neoadjuvant chemotherapy, like there is no survival advantage if we give the neoadjuvant chemotherapy versus adjuvant chemotherapy in an operable breast cancer. The only benefit is to treat neoadjuvant with neoadjuvant is to preserve and to conserve the breast. If patient want to preserve her breast, then it's okay, fine with me, and I will go for neoadjuvant chemotherapy, not the hormonal therapy, and complete my complete set of neoadjuvants. Yeah.
Excellent. Thank you, both of you. So the patient did choose to undergo neoadjuvant chemotherapy. Normally in ER/PR strong positive and HER2 negative patients, we don't expect to see a complete response because they will not respond as well as a triple negative or a HER2 new positive would. But she did respond very well, and we managed to achieve a clinical and radiological complete response in both her breast and axilla, and we went on to do a wire-guided wide local excision with an axillary clearance for her, and she did have PCR. So, would you like to, Dr. Sandeep, talk the meeting, everybody who's attending the meeting quickly through points in favor of neoadjuvant chemotherapy and why you would want to offer it? And you know, it's important for us to be aware of neoadjuvant chemotherapy, and that is when we will offer, rather than surgical excision biopsy or two-cut biopsy with ER/PR HER2 new status. Would you like to talk us through these points, please? Hello?
I don't think he is. Might be some internet issues.
Dr. Jain, would you like to take this? Dr. Jain? So I'll quickly run through these. So downstaging of tumors for breast conservation, and when we talk of newer advances, the role of limited surgery is now even being extended to the axilla. Initially, with sentinel lymph node biopsy, we were saving those axillae in which the tumor had not spread. But now more and more data is emerging that even if you have axillary nodal involvement post-chemo, if there is response, then you can de-escalate surgical treatment of axilla, even in axilla-positive patients. Also, by offering neoadjuvant chemotherapy, you provide time for germline mutation tests. And in a country like India, where we're going to see more and more younger patients with breast cancer, this buying time to understand the gene status or risk status is also very important. And also to individualize post-treatment prognostic information after seeing PCR and response to treatment. So just to, you know, that kind of covered the role for neoadjuvant chemotherapy. Would any of the panelists like to add anything to this?
Dr. Kaur.
Yeah.
Hi, Dr. Kaur.
Yes, Dr. Jain, we can hear you.
Yeah, so we are increasingly number of patients, like even with the smaller cancers, that who are being treated with the neoadjuvant approach. Actually, that's my major area of work. And it's very, very important before assigning our patients the right treatment. You know, as you said, the importance of correct pathological diagnosis. There have been recently a couple of cases that I came from, referred to me from India, in which even after 3+ immunohistochemistry for HER2, the tumors were sent for FISH analysis, and unfortunately, FISH ratio being indeterminate, you know, the tumors were labeled finally as HER2 negative. I mean, there's a big pitfall even here, like, you know, immunohistochemistry by a very astute pathologist, if it's read unequivocally, like, you know, 3+, we do not subject the tumors for FISH analysis. One is it's cost effective, and if it's a 3+, we don't need to do. Some centers do the dual kind of, like, you know, But as you said, it's a very, very important, like in a 3+, and if you believe your pathologist, there's no need to send the tissue for fish analysis. Number 2, I think for the neoadjuvant, I think the bar is going lower and lower, as you said, even for the N1 and 2 lymph nodes. N1 definitely, I would say, N2 also, because I think if we downgraded the tumor, we can do less mutilating surgeries. And I'm not talking about even in India, women are getting more aware. Breast conservation choices are available. Long-term mortality data with adjuvant radiation therapy after breast conservation is excellent. So I think this should be offered, especially if they're coming to a center where all these things are kind of techniques and the facilities are available. In the very resource poor setting, as I said, it all depends also on the number one facilities and the local treating doctors, like their
Dr. Jain, would you like to quickly? Hello, Dr. Jain. I think
with doing new adjuvants, we can talk about the ideal situations. And here also, where I am practicing, we do not sometimes practice the ideal situations. Thank you.
So just very quickly, if you would like to just apprise everyone about the importance of neoadjuvant chemotherapy in HER2 positive patients, even if they have T1 and 0 clinical disease, the role of pertuzumab in the neoadjuvant setting. Would you like to give us a quick overview of that?
So current status, as you said, we try to treat all these patients, especially node positive. I would not prefer probably adding, especially like in India, where we can add a lot of cost in other countries, pertuzumab, because now everybody throwing a kind of kitchen.
They are running short.
Dr. Kanchan, we are overshooting time. Can you wrap up, please?
No. So just one thing, in the resource poor countries, I don't think so there's a much addition to pertuzumab in the neoadjuvant setting. We can treat the patients with the only neoadjuvant trastuzumab approach based on what we get, a residual disease. Then you can randomize treat the patients with, nowadays TDM1 is available. So pertuzumab I will not add in every case, especially N0.
Okay. All right. Thank you. So, just to point that out, Dr. Deepak, how much more time do we have? And I can quickly then run through.
Actually, you have to wrap up. We are running short of time. We have one lecture and then lectures of our international faculty.
Would you like me to just quickly go through the slides myself?
Please,
yeah.
Just ask one or two questions to the which you feel feasible, and then for to the chair, expert chair for expert comments.
Okay. All right. So, I think when it comes to decision making for adjuvant treatment, especially in a patient with a profile like this, where you have a 28 millimeter grade 2 tumor with strong ER/PR positive, HER2 negative, in such patients, the role of gene profiling. Would Dr. Jain only like to give us a quick overview of this, or
again, I would not go you're running over time, but we are doing I don't think so. Reflex testing should be done in many centers, which is done. We have to sit with the patients what they want, for the small tumors like that. Sometimes they don't want to go through chemotherapy, and especially if you're thinking it may likely be indeterminate or low, even based on the pathology characteristics. There's an IHC4 kind of which is, we can say, poor man's kind of oncotype, but that is in the clinic with sit with the patient. So please do not do the reflex testing on the oncotype.
I think Dr. D'Souza wanted to add a point there. Dr. D'Souza?
So in this patient, if there's no financial constraint, then we can go for this Oncodex DX, and if we can avoid the chemotherapy adjuvant and go for hormonal treatment if possible.
Yes, agree, completely agree.
Excellent, thank you. So Dr. Deepak, I think I'd like to finish here only then, because with the way the time is running short, I think we just take the expert comments from the panel in the end. Dr. Deepak?
Thank you so much, Dr. Kanchan Kaur. It was wonderful listening to you. And I'm
My
sure,
life was quite difficult with so many panelists.
yeah, I'm sure all our general surgeons who are listening, they must have done this message. And your throughput biopsy, I think, was very important for all my friend general surgeons to go for it. And of course, the triple assessment is still a gold standard. And I'm sure they must be much wiser as far as the breast conservative surgery is concerned.
Yeah.
Thank you so much.
Can I just add one
Dr.
quick point?
Kamaluddin sir, are you here?
Yeah, I'm here. Thank you.
Please give expert comments, sir,
Yeah.
and then we'll wrap up.
Okay, so it was a great discussion. I appreciate. But what I want to add is that very recent there was a meta-analysis came out where they have shown there is a survival benefit both OS and EFS from NSCT. So neoadjuvant chemotherapy, after all this additional benefit, now there is a proven benefit of survival. So thanks to the moderator for bringing up the issue of neoadjuvant chemotherapy, even this situation, because this is giving us so many benefits and we should really use it. So thanks all, and I think it was there was many messages that we should take home. Thank you.
Yeah, I think this was a very important comment because there's a recently survival data, but I didn't say on that, there's survival data because early control of micrometastatic disease with a neoadjuvant. Thank you.
Thank you, Jan sir, for joining us from Louisville, Kentucky. Thank you, Kamaluddin sir, for joining us from Bangladesh. Thank you, panelists. Thank you, moderator. We are running actually short of time, so I'll request Dr. Nitika, our coordinator, to take over from moderator. Yes,
and
please.
Thank you, Kanchan ma'am, for a very enlightening lecture. I'm sorry we could not give you more time for this. Can I invite Dr. Kanu Charan Patro, the oncologist from Vizag, to speak on the progress of radiation oncology from ortho voltage to mega voltage era. I request Dr. Dharamveer Jain and Dr. Sanjay Kalsotra, Professor and Head Department of Anesthesia, GMC Jammu, to kindly chair this session.
GMC Kathua.
GMC Kathua, I'm sorry. Sir, Dr. Kanu, sir. Are you on board, sir?
Dr. Kanu? If Dr. Kanu is not here, we can start with the next lecture then.
Actually, he was on line. Dr. Kanu,
Dr.
sir?
Kanu? Sunidhi? Sunidhi?
Yes, sir. He is here, sir.
He's online, sir. He's still online.
Okay. Then ask Dr. Kanu to start and put on his slides.
I will share his slide.
Or if some connection error is there, then we can start with the next lecture and ask Dr. Kanu to take on afterwards.
Sir, I had word with Dr. Kanu. I have word with Dr. Kanu. There was some emergency, so he said that you go ahead. I'll come after 5 to 10 minutes.
All right.
Then
we can proceed to Dr.
we'll invite him after international lectures. Okay.
All right. We can proceed to Dr. Anil Mehta's lecture.
We will proceed to Dr. Anil Mehta's lecture, and I'll ask Sunidhi to please put on the slides of Dr. Anil Mehta.
Yeah. All right. So we have Dr. Anil Mehta, who's Professor and Head Department of Gynae Ops at GMC Kathua. He's going to speak on gynecological malignancies, workload and management in third tier city. I would request Dr. Sanjay Kalsotra, sir, Professor and Head Department of Anesthesia, GMC Kathua, to kindly chair the session.
Thank you. I'm here.
Thank you very much, Dr. Deepak, to have invited me to speak on a very in the field where we are as a medical college have started taking what we would call baby steps. COVID, as I was listening to previous lectures, and it was very aptly said that COVID has come as a dark cloud, and every cloud has a silver lining.
Please mute others.
I request other people to kindly mute their devices.
Ravinder, can you mute?
Already done,
Ravinder,
sir.
mute
Already
others.
done, sir.
Mutate others.
Now, Dr.
So you can start your session, sir.
Yes, sir.
Dr. Anil Mehta, sir, you have to unmute, sir. Anil, you have to unmute, sir.
Okay. I'm thankful to Dr. Deepak who have invited me to speak on our experience about the gynecological work in new medical college GMC Kathua. And it is a new medical college which was converted from a district hospital, and now it started working as a college. So initially we started taking the load of the obstetrical emergencies and the gynecological work, elective work. But then I was listening to previous lectures, and somebody very aptly mentioned that every cloud, COVID has come as a cloud, and every cloud has a silver lining. So silver lining, which I see during our work, last 1.5 years of work in GMC Kathua, was that because the elective surgeries, we stopped doing elective surgeries there, and as a matter of a departmental policy and as a matter of college policy, we decided that we would be not ignoring the adnexal masses and early malignancies, because we realized that these patients had no place to go during lockdowns. And we started taking them, we started working on them. Although this was a college, we did not have much experience about gynecological work. Next slide, please. We are all aware about the statistics around in India. The National Cancer Registry Program, we know that the number of cases are increasing, and they will further increase by 2025. Next. This is a dictum I strongly believe in, is that cancers in developed countries are picked up in developing stage. But irony and the unfortunate thing about our work in developing countries, because we are low resource countries, and the cancers are in developing countries are picked up in a developed stage. Next. This is how we can know that from these two maps we can show that in India also the cancers are increasing. Next. These sustainable goals, and it is very nice of the governments have to taken the cancers, especially the gynecological cancer, CA cervix, into a program where they are under the NCD program, and we all will be now working for the screening, early detection and treatment of CA cervix, and contribute to the control of the cancers. Next slide, please. This is how it is now happening, that the CA cervix has really started all over India. CA cervix incidence is also started decreasing, and their progress, if you take the age adjusted incident rates, you find that now the CA cervix overall is reducing. Next. Well, although it has been for last so many years that there is a paucity of uniform treatment protocols for various stages. Now there are set protocols we require to learn them and apply them for treatment of patients and benefit the population at large. Next. As we know that the population is increasing, the number of patients in the society is increasing, and the expectancy is also increasing. So we are expected to have more number of cancer patients, especially the gynecological cancers. And in India, as I told you, majority of patients, this is a figure, 75 to 80% of patients, they are diagnosed in advanced stage. And the late presentation is attributed to so many things. This is lack of awareness, denial about the disease, far-flung areas, then patients traveling to big hospitals, and there they have so much of patient rush, and lack of screening programs in the society, and diagnostic facilities, vast distances. I told you that these are the things which are associated with the delays in the treatment of these patients. Next. The problem is going to increase. I mean, we have a lack of workforce. We have a lack of onco-trained physicians, aware health workers, the technical staff to do screenings, and you require very trained pathologists to comment on the material which we have for the diagnosis. And there is a growth of population, but now, as Dr. that there are improvements in the cancer survival rates, and if somebody has to have a disease today, it is to have a cancer in early stage, because it has got definitive treatment now. Next. Now these are various initiatives which have been taken by the governments. Regional centers are being established in various areas, and under the treatment program of prevention of cancer control, like I mentioned about the Government of India initiative for NCDs. At every, even all states are having these programs functioning very fine. And now we have also started in Kathua, which is a college which is 1.5-year old, and we have started taking baby steps in establishing a center which would have, apart from the obstetrical and gynecological work, we will be undertaking the responsibility for even the gynec onco patients. Next. There are two cancer institutes which are about to come in Jammu, one in Jammu and one in Kashmir, and this is awaited and probably delayed because of the corona. And once corona epidemic, pandemic, it settles, I think these things will come up for the larger benefit of patients. Next slide. Now, what I believe, and what my department in OB-GYN GMC Kathua, we believe that the gynec oncological division can be very well started within the departments of OBS and gynae of medical college, without any additional infrastructure and without any compromise on quality of care. But what you require is to treat patients and train yourself for that. Now, radical surgeries are known to have much higher complication rates. They have higher complication rates, but in GMC Kathua, we have upcoming Department of Anesthesia. We have requested them for supporting in our in surgical programs. We have a pathologist with us. We have oncologist. We have a radiation oncologist in Dr. Deepak, and we have designed a team for that. And I think once this COVID crisis is slightly on the lower side, we'll be taking it on a much larger account. In a country like India, where institutions have to really stretch themselves to work, we can always come now. Something about GMC Kathua. I would tell you that we are converted from a district hospital, which was only meant for obstetrical care, and now we are taking the obstetrical care, plus we are taking the gynecological care. And because of the zeal and enthusiasm shown by my faculty in treating the onco patients, the purpose is to initiate and provide care for a population of around 6 lakh people. That is the Kathua district, and the unit is also the basic requirement of our ongoing DNB program. We have to establish a onco unit, which we have started along with the Department of OB-GYN. And this department has 1 professor, 2 associate professors, 5 assistant professors, 3 senior residents, along with 3 JRs. But as a unit, the team has got no formal training in gynec oncology. And purpose of this effort is to involve the senior faculty into a screening program and of these malignancies, a diagnostic approach, and evolution of operative skills. Whereas the junior faculty is designed to develop them into an authenticated and screening program for the protocols for pre and post operative management also. Last year, the effort was made to recruit the gynae ICU, backup from the departments and backup from the blood bank facilities. At the end of 1.5 years, a retrospective analysis of results was carried out to see the feasibility of gynecological oncology unit in GMC Kathua. The specialized oncology clinic was started along with the OPD of general OBGYN, and oncology work was allocated to one of the senior associate professor and assistant professor who had a interest in the onco, and they wanted to train themselves too. And in association, 1 senior radiation oncologist and a senior pathologist. We have a very good pathologist who has a real know-how of the pathological work of the gynec onco patients. The routine oncology work was carried out in all 3 units of the gynae, but documentation and analytical work was assigned to 1 particular unit, which will carry on the onco work in future also. The office of the radiation oncologist was on the same floor, that was about 50 meters away from the OPD of OBGYN, and the pathology department was around 100 meters away on a different floor. The proposed gynae ICU was discussed with the HOD anesthesia. It is about 50 meters away from the OPD. Senior surgeons and urologists are involved in the gynec onco team. Next. The program was enthusiastically started in November 19, after the department enrolled itself into the DNB program and was very adversely affected by the COVID pandemic. Despite that, following is the work done from that period till date. We have recruited colposcope around 1 month back, and we have started doing colposcopies with proper documentation. We have done about 7 colposcopies, and we have taken about 75 pap smears and 50 liquid-based cytologies. And there are 1 patient with HCl and HPV DNA we have detected. Next. There was a diagnosed case of CA cervix, and this was the first case. There was a patient of CA body, They're not the CA cervix, but this patient was stage 1A1. Due to lockdown, she had no place to go, and no hospitals were there to take them. We took this patient, we operated this patient, and then this patient was referred for further treatment. Next. These are the missed opportunities. One of the patients came in COVID time, and she was probably stage 3, and she had she was 3B, and she was missed to the treatment, and she went to Delhi for the further treatment. Because of the COVID problems, we could not properly manage this patient. Next. This patient was around 90 years old and she came with bleeding PV. An examination, she was frank carcinoma cervix, and no other treatment could be offered in COVID times. We sent this patient to Dr. Deepak and she referred her for chemoradiation. These are, we diagnosed 4 ovarian malignancies. We could operate only on one. She was dysgerminoma. She now is on chemotherapy, and 2 patients were referred to the major center of Jammu, that is Jammu Medical College, and 1 patient left against the medical advice. Our limitations are, we have a few limitations, and these limitations are because of the COVID times. And once COVID times are over, we will be developing our institution into a stronger institution as far as the onco work is concerned. Next. However, after managing a few cases, locals are now aware of the oncology services, and many patients are turning up for screening purposes. They are coming for diagnosis and even for second opinions. The faculty has geared up for an intensive oncology workup, which has been appreciated by the female population, which is visiting for screening programs of the oncology clinic. Next. This is our vision for the future, and we'll train our faculty members, especially the ones who have taken for onc, and we will be tying up with certain centers, and we will be doing routine LBC and HPV DNA. We have started the routine colposcopy. Far future is that we will be taking frozen section also a part of the workup. Next. Next. Thank you so much. And we hope that we'll be in the next meeting, next Crabicon, we will be having a larger number of patients worked up for presentation. Thank you so much.
Thank you, Dr. Anil. A very nice and a crisp presentation about whatsoever we are doing at Kathua. We have limitations, but with time and factor and due to this COVID crisis, we couldn't grow as fast as we should have gone. So never, your department is doing a wonderful job, and hopefully we'll go step by step, and all the best to your department for the future also.
Thank you.
For time constraint, please invite the next speaker.
Yeah, I just wanted to confirm is Dr. Kanu online? Otherwise, we can start Dr. Ajay Sandhu's lecture.
You can start with the next session.
You can start with the next session. Kanu will join.
Okay. I request Dr. Ajay Sandhu, who's radiation oncologist based in San Diego, California, to present his lecture on the role of stereotactic body radiotherapy in lung cancer. And I request Dr. Gisab Praseko from Nepal, Dr. Vijay Anand Reddy from Hyderabad, and Dr. AFM Kamaluddin from Bangladesh to kindly chair the session.
Hello, good evening.
Good evening, sir.
First of all, I would like to thank Dr. Avrol and his team for inviting us in this your great program. And we are delighted with this. And I think we'll go with the next program, keynote lecture from Dr. Ajay Sandhu, and the topic is role of SPRT in lung cancer. Thank you.
Thank you. Good evening, good morning from US. Can somebody load my talk, please?
So we'll be next, huh?
Dr. Ajay, you are...
Okay. Which lecture is going on?
So we're going to have your lecture, Dr. Ajay.
Yes, thank you.
Okay.
So I'm online. Can
right,
everybody hear me, please?
Yes, sir, you are audible, sir.
Okay, thank you very much. And I'd like to thank Dr. Abrol for inviting me and giving this opportunity. So I'll be speaking on a role of stereotactic body radiation therapy in lung cancer. Next. So this is my campus. Actually, many of radiation oncology members of AROI have visited me here, and Dr. Deepak also was here a few years ago. It's a beautiful campus on Pacific Ocean. Next, please. So I'll start with the topic. SBRT stands for stereotactic body radiotherapy. However, there are many other names too. In Europe, they call it stereotactic ablative radiotherapy. Some people also call it SRS or stereotactic radiosurgery, which is usually confined for brain. Other names, medical oncologists and even my patient, they confuse it. They call it cyber knife or gamma knife, stuff like that. Next. What is SBRT? So stereotactic body radiotherapy essentially is a very highly three-dimensional conformal radiotherapy, which uses, stereotactic targeting and with the idea to decrease the normal tissue dose and give very high dose to the target. And we use several systems, and I'll discuss that, including motion management. By definition, it's a form of external beam radiation therapy used to very precisely deliver a very high dose to the extracranial target, which could be in the lung, liver, bone, and use a very small number of fractions, typically less than 5 or 5 or less than 5. And we use very specialized treatment planning to achieve these goals. Next, please. And I know that in India, many centers are trying to start this technology. So I thought it's important that before you implement SBRT, that you establish the scope of the program, including what sites you want to do to begin with. Start with what kind of dose fractionation and treatment planning goals you have. Determine the equipment. What kind of patient positioning, treatment delivery. It's very important to have trained, people in the program. Establish quality control by having acceptance and commission testing procedures done, and same way establish simulation planning, delivery, and quality verification guidelines. Very important that you have trained, not only trained physicians, but also trained physicists and trained therapists. Next slide, please. So what's the rationale for SBRT? So we started doing this since 2006. And this is a study which shows what's the natural history of untreated stage 1 non-small cell lung cancer. Because many people would argue, and we have the discussion at Tumor Board, that it's a very early stage lung cancer, let's leave it alone. But this is a study close to 1,500 patients who are not treated and were just stage 1 non-small cell lung cancer, and their median overall survival was just 9 months. So, which means that vast majority of untreated patients will die of lung cancer, and their 5-year overall survival is quite low, as you can see, 6%, and even for T1 tumor, it's only 9%, and very low 5-year cancer-specific survival. So, bottom line is that even for stage 1 lung cancer, therapy should not be delayed, and we should treat these patients. Next, please. So, there's always a question, because SBRT is obviously a more expensive technology, whether you should do conformal radiation or not. So this is actually a study published last year in Lancet Oncology, which interestingly compared conformal radiotherapy to stereotactic body radiotherapy. This is an Australian study published in Lancet Oncology. Next, please. So it clearly showed advantage for SBRT. As you can see, the upper curve is for SBRT. So there was, for local control. So there was clearly a higher local control with SBRT versus conformal radiotherapy. And interestingly, there was no increase in major toxicity, even though they gave much higher dose with SBRT compared to conformal radiotherapy. Next, please. And same was true for overall survival. So there was improvement in overall survival using SBRT. So the local control clearly translated into improved overall survival using SBRT when compared to conformal radiotherapy. So their conclusion was that for early stage lung cancer, SBRT is preferred modality over conformal radiotherapy. Next, please. So what are advantages of stereotactic radiotherapy? I'll not go into detail, it's a busy slide, but there's a radiobiologic advantage, which leads to improvement in local control and survival. You can reduce the normal tissue toxicity because you can reduce the normal lungs being irradiated. Its patient is convenience, also shortened treatment duration, less number of fractions, and like I said, there's minimizes repopulation of the tumor, in addition, improves quality of life. So all these advantages, and for India, you can treat like more number of patients because you have less number of fractions to treat. So that's also advantage. You can have higher output. Next, please. So what are indications of lung SPRT? Typically, most of the trials used early stage, usually T1, T2. Most of the trials had a cutoff of less than 5 centimeters. But we have now developed a lot of experience, so I many times use SPRT also for larger tumors. Most of the time, they have to be clinically node negative, usually by PET scan, and if there is any suspicious node, then we usually use EBUS and very rarely mediastinoscopy. Again, you have to keep to account the location, peripheral versus central when planning SPRT. Most of the time, we use it for medically inoperable because surgery is still standard of care. But I see a lot of patients who actually opt for SPRT even though medically operable. We also use it for oligometastasis from various primaries. And the definition of oligometastasis is not standard, and I'll not go into detail because I'll be diverging from my topic, but this typically, if they have less than 5 metastases, we sometimes use this for local control. And we also sometimes use it for palliation in patients who had previous radiation and the tumor is amenable to this technology. Next, please. So now I'll go over some of the basic principles and nuts and bolts of SPRT in terms of planning. Next. So in lung, when you're treating a lung lesion, why is motion a problem? This is where I live. They have a horse racing season this time of the year. Next, please. So the reason is that in lung, there are many kinds of motion happening. There's, diaphragmatic motion, there's cardiac motion. Next, please. So the answer is, why is motion a problem? Because motion compromises delivery of treatment. It's difficult to treat a moving target. Like same, it's difficult to shoot a moving target. We are more likely to miss a moving target. Next, please. Next. So what will that result? If you have a poor motion management, you'll have a poor local control because you'll be unable to deliver adequate dose, which will be limited by normal tissue toxicity. Next. And therefore, or you could have a geographic miss. Therefore, you are not able to deliver the desired dose. If you have proper motion management. Next. Then typically, you can have a dose escalation because you can reduce the margin, you can accurately localize the tumor and improve local control. Next. And also, with proper motion management, you can avoid any geographic miss, and that also leads to improved local control and reduced normal tissue toxicity. Next. So this is the variant system that we use, real-time position management system. You can see you can coach the patient how to breathe in a consistent fashion. We do a 4-dimensional CT.
Okay, I have one question. Can I ask you a question?
Please go ahead.
Now in Nepal, we don't have actually SBRT program till now, but we are trying to start and initiate the program. Okay, now we can start, I think. It's okay now.
Yeah, I think we have to go further ahead, yeah.
Yeah, you can continue, yeah.
Keep moving forward. Next one. Okay, so I was alluding to the previous one. I think the previous one. Okay, anyway, so I was going by the 4-dimensional CT scan. So that's what we do for planning. Basically, you have the scan done in different phases of respiratory cycle, and then you combine them together, and the whole set is what we call a 4-dimensional CT scan. So we can either treat the patient, if the motion is not that much, then we can treat the patient throughout the whole cycle of respiratory cycle, or you can gate it like you have on the middle 30-70, or you can also track the tumor, which is the most sophisticated, and you can then limit the dose to normal tissues. Next, please. Next. So how do we contour the target? ITV stands for internal target volume. Typically, we use average scans for planning, and usually we use maximum intensity projection in the lung for contouring, because that has a higher density, so you can see the tumor very clearly. In some situation like liver cancer, you may have to use minimum intensity projection. So it depends on situation. So we usually work with the physics and dosimetry team to decide what kind of scans to be used for target contouring. And typically, I'll always train the resident that we should look at both the lung windows and a soft tissue window to appropriately to find the target, because sometimes you can miss it. Next. So this is just the concept of internal target volume. So it accounts for the whole respiratory motion so that you don't miss the target. Next one. Again, showing the concept of how to generate internal target volume. Next. And this is just to show that we're treating the whole motion of the target, so we are not missing the tumor, which improves the local control and also limits the dose to normal tissues. Next one. We also use PET scan for fusing, because sometimes there could be atelectasis or other things associated with tumor, and then you may not be able to define the target appropriately just on the CT image. So we also fuse it with the PET scan. First of all, we do define the target and also help with the target definition, because sometimes these patients have multiple lung nodules, some of them are benign. So also it helps to identify really which one is the malignant target that you're trying to treat. Next, please. So then the question comes, what's the optimal dose? What's the optimal biologic effective dose? And this is an older study where they looked at various doses, and they found that the best overall survival was in the medium to high biologic effective dose in the range of 90 to 150. Typically in our center, we use more than 100 BED for what we call SBRT treatment. But if you increase it too high, then sometimes very highest BED may also lead to more complications, because you're giving them very high dose normal tissues too. Next one. So these are various schedules. As I mentioned, typically we use 12 gray times 4, which is a BED of 106. We also use 10 gray times 5 for central lesions or for chest wall lesions close to chest wall, so that we can limit the dose to normal tissues. Now, 5 gray times 10 has a lower BED. We don't use it for definitive treatment, but sometimes we use it for palliative situations. Next, please. Next, so just to highlight, next slide, that all prescription doses are not equal. So you have to look at how the dose was prescribed before you start implementing your program, because what kind of dose calculation algorithm is used, whether they use the lung inhomogeneity corrections, where was the dose prescribed? Was it to the ITV or PTV or isocenter? Most of the time now we prescribe to PTV. In the past, many studies, they used to prescribe to isocenter. What kind of PTV margins were used? What's the location? What kind of dose fractionation was used? To all these, what kind of methodology they did do gating? Was it tracking or breath hold? So all those have to be taken into account, and then the dose constraint for organ tissue. So that's how you decide what kind of prescription dose you'll be using. Next, please. So this is to show that if you use a higher biologic dose, like more than 100 BED, there is a survival advantage as well compared to a lower BED. Next, please. This is our own experience, which we published a few years ago, again, using SPRT for early stage lung cancer, showing almost 90+% local control with very minimal toxicity. There was no grade 4 or 5 toxicity. Next, please. So I thought I'll briefly discuss what's a toxicity, which you should be aware of. Usually during treatment, patient can experience fatigue. They can have fever and cough or pneumonitis. There could be chest wall pain. There could be, in extreme case, fibrosis, hypoxia, and leading to oxygen dependence. Fortunately, we don't see those very commonly. If you're careful with the radiation planning, again, it can affect the pleura, depending on the location, can cause cardiac complications. Rib fracture is quite commonly seen, especially in peripheral lesions where the tumor is, or planning target volume was close to the rib. But it's really not a big deal. I usually don't compromise my dose based on rib or chest wall dose, because it usually causes some chest wall pain, which usually heals up later. Brachial damage, brachial plexus damage is a serious problem, so you have to be very careful. We usually contour that and make sure that the dose delivered is, depending on the dose fractionation that you use, is not higher. In central tumor, you could have bronchial toxicity as well. Usually the lung functions decline transiently. Next, please. Again, these are the factors, again, as I mentioned, so it's very important what kind of dose was used, whether it's a central lesion versus peripheral lesion. So all those factors have to be taken into account before you counsel the patient of what kind of toxicity to expect after SPRT. Next. So this is an example I always use. This is a patient I treated actually many, many years ago. She was in her 70s, had left lung cancer in the beginning, and she had left-sided lobectomy done, and she was a heavy smoker and had compromised lung functions. And then on the left side, she had a squamous cell carcinoma. And then we found a nodule on the right side, as I show here. Next slide, and that was biopsy, and it came as adenocarcinoma. So she had a new primary. Next, please. So essentially, we decided surgery was not an option anymore because of compromised lung function, and she already had one surgery done. Next, please. So we decided to treat her with SPRT, and this was a PET scan which was fused with that. Next. So she did very well. We gave her, I think, a dose of 12 gray times 4, which is our standard protocol. And now, of course, we use ARC therapy, but at that time we were using, a different technique. Next, please. And so she lived for several years, and this is a scan at 1 year. The tumor is gone, and there's some treatment changes. You can see some scarring of fibrosis. Next, please. Again, another CT scan showing same treatment-related changes. A complete response, tumor is gone, and I think she lived for 3-4 years after the treatment, and then she died of other problems, other medical issues. Next, please. Next. And this is a lung functions pre-treatment, which was very bad, and actually she had some improvement after therapy. And we see sometimes, instead of decline, you also see improvement in the lung functions. Next, please. So the other question that often comes up in discussion at the tumor board is, how do you compare SPRT to surgery? These days, we also see many medically operable patients. So this is a Japanese study which actually compared surgical series to SPRT, and you can see where it's stage 1A or 1B. The last one is SPRT, and the other 3 are surgical series, and you can see that the outcome is similar, whether you did SPRT or surgery in medically operable. Next, please. And then the only randomized study we have is a pooled analysis of 2 trials which could not accrue, Roselle and the STARS trial, but I'll just show the results briefly. Next, please. So in this, they compared patients with surgery versus SPRT, and again, they only had like 58 patients, I think, enrolled. but just to point out that there was no difference in overall survival or recurrence-free survival using SPRT, and actually the death rates were in favor of SPRT. I think I'm kind of running short. Do I have some more time? I don't know how much time I have, but I'll probably quickly go over that next one. So this is overall survival again. The blue line is SPRT. So it was actually in favor of SPRT, but because of small study, we cannot make that conclusion. But at least it was not inferior to surgery. Next, please. Again, this is recurrence-free survival. Again, similar outcome whether you did SPRT or surgery. Next. And adverse events, there was no grade 4 or 5 toxicity with SPRT or they call SABR, stereotactic ablative radiotherapy. There were only 10% patients had grade 3 or lower events. With surgery, there was death, and there were higher grade 3 to 4 events, so which included lung infections, chest pain, bleeding, fistulas, etc. So bottom line is that SPRT to me is safer with similar outcome. So when patients come to me who are even medically operable, I usually offer them and I show them whatever data we have. And many patients actually want to be treated with SPRT rather than undergo lobectomy, which is a major procedure. Next, please. So this is another study where they actually compared surgery to radiation or SPRT using meta-analysis of all the studies with propensity score studies. I'll not go into detail, but again, their conclusion was that for early stage non-small, and these are not randomized studies, so they showed that the survival was better with surgery, and the reason was that the patient was selected in favor of surgery who had less medical comorbidities. But there was no difference in lung cancer specific survival, which means that if you appropriately select patients for SPRT and surgery, the outcome would be probably similar, and SPRT probably would be safer. And so we do have a VALOR trial ongoing, which is accruing quite well in the US, and hopefully that will give the answer to this question. Next, please. We also see a lot of patients who really have poor lung functions and a lot of emphysema and stuff like that. So it's difficult for them to get a biopsy. And this question always comes up in the tumor board. So we do treat a fair number of patients without pathologic diagnosis. And these are the guidelines. So we typically make sure that the patient is discussed in the tumor board. We discuss with the radiologist that this is a new or growing lesion on CT, and there's a higher clinical risk like a smoking history and they're PET positive. And most of the time, we are more than 95% accurate. So the benign diagnosis will report only less than 5% in these kind of patients after surgery. So sometimes they have reported inferior survival with stereotactic without histology, simply because this is a patient population who have more medical comorbidities, so they could not even undergo tissue diagnosis. But one has to be careful, especially in a country like India. There could be higher for PET positive due to infections like in India, probably tuberculosis and etc. Next, please. So we published our experience using stereotactic radiotherapy with or without confirmation, and we found similar outcomes. So it's reasonable to treat patients who it's difficult to obtain a biopsy because of bad lung function, and when the suspicion of malignancy is high, to treat presumptively with stereotactic treatment. Next, please. So I will end my talk by showing some recent ASTRO evidence-based guideline on use of stereotactic body radiotherapy for early stage non-small cell lung cancer. Next, please. So their conclusion was that surgery remains the standard of care because we don't have yet good randomized data to support SPRT, and their ongoing studies, as I mentioned. So any patient with operable stage 1 non-small cell lung cancer should have a thoracic surgeon evaluation, even if considered for SPRT treatment. And usually we discuss in the tumor board. So for patients with standard operative risk, usually surgery is a standard treatment. But SPRT could be recommended either either in a clinical trial setting or if patient prefers that. Next. However, patients who have a higher operative risk, like the bad lung functions or other cardiac issues, other medical issues, who cannot tolerate lobectomy, there should be a discussion about SPRT, because sometimes surgeons will want to do wedge resection. And I didn't have time to show the data, but wedge resection typically has a poorer local control than SPRT. So, so patients should be informed about this treatment, and therefore, we should consider this therapy when lobectomy is not feasible. And also, they recommended that if it's a central tumor, then probably you should use at least 4 to 5 fractions rather than a shorter treatment fractionation, because of higher probability of complications. I therefore conclude by saying that SPRT has emerged as a safe and effective modality in treatment of several cancers, including early stage lung cancer, and it's now increasingly employed for medically inoperable. And I also have a few patients who are medically operable and who opt for this therapy. Prospective trials are testing the role of SPRT in patients with operable lung cancer, and hopefully, as I showed a smaller study, probably we'll replicate the same results, and hopefully we'll have similar outcomes, and SPRT may become the standard therapy even in medically operable patients. Thank you very much.
Thank you, Dr. Sandhu, for your great presentation, and it was very fruitful to us. Now, I have one question.
Sure.
Do you get a lot of lung fibrosis around our treatment site? Do you get a lot of lung fibrosis?
So, I didn't have time to go into detail, but the publication, we've looked into our experience. So we have, in our own series of about 500 patients, we've only seen grade 1 and grade 2 toxicity. So they do develop radiologic changes. Almost all patients will have radiologic changes, but clinically, they are asymptomatic for most part. Any grade 3 pneumonitis is less than 5%. So overall, it's a very safe treatment. And the toxicity, we didn't see any grade of 4 or 5 toxicity in our whole series. So we didn't have any deaths or even any serious side effect.
It's very good thing.
I have a
please.
I have a question. Dr. Sandhu, this is Juan Yap. Thank you for excellent presentation. My question regarding the use of SBRT. SBRT for retreatment for patients who have radiation therapy before. What's the recommendation on the dose vaccination and whether the tumor is central located or non-central location?
Yeah, so that's a very tough situation. It depends on many things. So it depends on whether it's a recurrence in the same area. It also depends on the location, and as you mentioned, central versus. It also depends on, what the lung functions are, what overall, performance status is. So we do treat, and also time duration, how much time has elapsed between previous treatment. Most of the time, for retreatment to be effective, we have to still do a dose of at least 100 BED to be effective. If we are in a more definitive setting. But if you're in a palliative setting, then it doesn't matter. Then we can give a lower dose. But if in a definitive setting, if it's a recurrence in a different location, definitely we are very aggressive. If it's in the same location and there's nothing critical there, we can still go pretty aggressive, especially if a lot of time has elapsed between the previous treatment. But there is no good data on that, unfortunately.
Thank you.
Nice to see you, Juan.
Thank you, sir.
हेलो अजय पाल।
हाँ जी, how are you?
हाँ जी, क्या बस ठीक है। आपके क्या हाल है? बड़े दिनों बाद देखा।
Yeah, nice to see you. Corona के साथ what to do? You can't meet and cannot have a.
बस next year ही मिलेंगे।
Okay, thank you. Yeah, I'm looking forward to see you.
Okay,
okay, thank you.
Thank you, sir. Thank you, sir. And I want to say one thing that this year Albion Kirkchurch Award has been awarded to. We are honored that Dr. Ajay Pal Sandhu has accepted this award, and it will be emailed. A certificate will be emailed to you, sir, and silver plaque will be given once you come over to India. Thank you, sir.
Thank you. Thank you so much. I'm honored. I'm honored with this. Thank you so much. I really appreciate it.
Over to chair.
Thank you, Doctor.
Dr. Kamal, do you want to add anything?
No, it was an amazing lecture. I was just enjoying. We have very limited experience, and the huge experience of Dr. Sandhu is really amazing. So I would like to have one comment from Dr. Sandhu that the Japanese, they have some data of higher number of fractionation, 8 to 10 fraction with almost 90 to 92% local control. BD is well fine, but do you have any comment on those, that they are doing some really 8 to 10 fraction?
Yes, you're right. So especially for central tumors, they are sometimes using 7.5 gray to 60 gray total dose. So they're using 8 fractions regimen. And even Europeans are using that too. Problem in US is we cannot use that, not because of medical reasons, but because of insurance reasons, because insurance companies define stereotactic radiation therapy as 5 fractions or less than that. So if we use anything more than that, we cannot bill the patient for stereotactics. So it's a logistical reason rather than a medical reason. But yes, I think especially for central lesions, the more protracted treatment you have, the less toxicity. So definitely, you're right. They have reported good outcomes with very minimal toxicity for central lesions using 8 fraction regimen.
Yeah, because what I'm telling, say, country like Bangladesh, we are doing in a very limited center. So going very aggressive like US, because I was in Pittsburgh in UPMC, I have seen how aggressive they are. I mean, what do you think that a beginner like us can go with this conservative approach with a minimum toxicity, even for the peripheral lesion also? And once we are prepared, maybe we can go for more aggressive dose fractionation, because here logistic is not like you, because for us 5 fraction and 8 fraction is not going to make a big difference, but one mishap can make a big blunder on our beginning. You know, we are in a small country. If there is a small mess, that can make a big noise and that can stop our journey. So do you think that country like us can start with this type of a bit conservative approach?
Absolutely. So when I started, you know, I did my first patient in 2001, and we didn't even have the proper technology at that time. And we actually used to use 10 fraction regimen that time, and we didn't call it stereotactic, even though it was same approach. So we used 5 gray times 10. So that's a approach that we initially begin with. And then once you become more confident, then you go to higher dose per fraction regimen. I absolutely agree with that. So that's one we used. And now we use that 5 gray times 10 mostly for palliative. But absolutely, that's how you should start. And, you know, then once you build up confidence and you have a team, and then you have high quality assurance program, certainly then you can be more aggressive. I agree with that.
And last, I want to make one question to you, that in our country, we don't have much primary lung, because we don't have any screening program, because majority of our patient comes in stage 3, you know that. But we are getting so many metastatic cases from breast and other, and we are getting very good result for SBRT lung metastasis, because it is not curative. I agree with the primary lung, but it is giving a wonderful local control, and patient is failing in somewhere else. What is your comment about this?
Yeah, so I actually have a whole presentation on, I did it last time when I came to Delhi, on oligometastasis, and I didn't go into detail because I didn't have time, but definitely there is now data to support even improved overall survival by adding local therapy in selected patients with metastatic disease, including breast cancer, including colon cancer, including prostate cancer, and so even including lung cancer. So there's a study from MD Anderson which actually showed that even in oligometastatic lung cancer, with addition of SBRT, you can improve overall survival. So definitely that's an area where you can use it, because I agree that with lack of screening programs, you don't detect early stage lung cancer, but definitely you get a lot of metastasis. But it's very important to have proper selection of patients. You don't want to do SBRT in patients who have a lot of metastatic burden, and then in that situation, it's mostly for palliation. It doesn't improve the outcome. But if there's a selected patient with limited metastatic disease, certainly that's an option.
I understand you. My question is,
thank you.
What do you think
very
about
much.
the use of the SBRT for abscopal effect in patients who would have multiple lung metastasis from melanoma or renal cell cancer? Not patient also receiving chemotherapy. What are you thinking on the abscopal effect of SBRT on treating just one?
Yeah, so that's still, I mean, it's in the clinical trial setting. So we have actually, at my institution, we have an immunotherapist, Dr. Shirabi, who's quite well known, and he has a clinical trial looking at the same aspect. So we are using, especially for melanomas and stuff like that, where there's now more data emerging. But yeah, so definitely, yeah, that's an upcoming thing. And that's a very good point.
I think with this, thank you, Dr. Sandhu, and we can conclude this keynote lecture, and we'll, I think, go to the another keynote lecture.
Thank you very much.
Thank you, sir. Can we proceed to the next lecture?
Yes.
I now request Dr. Hyeon Gyap, radiation oncologist from Miami, Florida, to kindly speak on protons in cancer care.
Thank you very much. Thank you so much for being invited here for this. And I've been listening for the last few hours. I'm quite impressed with all this discussion and all these sessions. So I just like to talk about the use of proton therapy for cancer. And I know there's a lot of radiation oncologists, experts here, and also there are surgeons and medical oncologists and other specialists. So I'm trying to keep the session a little more on the general and for 50 minutes time frame. And for the bandwidth reason, I'll just turn off my video so the sound can be better. So proton therapy for cancer treatment. And this is, I want to acknowledge there are no conflict interest. And I want to thank you, Dr. Deepak Apro, for invitation, and also the organization, and also the author that I cited the work in this presentation. Next. So in cancer treatment for any size, so we have three modalities, surgery, radiation therapy, and biological. And the user combination, or the best combination, depend on disease size, location. And I think we only have to look at from a mile away to look at it before focus on one small technique like proton therapy. Next, please. So to look from the scope from afar, I mean, cancer is a very complex problem, and we have to look at all different aspects or different angles from cancer. And our medical oncologists are very clever and very friendly in this. And I want to put on emphasis on radiation therapy. Next slide, please. And next, so we have all the different pathway, different mechanism, and understand them how, where, and when. And to make medicine a little more personalized for cancer treatment. And this has been pioneered in the last 10 years from our medical oncology college. Next slide, please. And so I'm not going to go to more discussion on this, but this is a kind of reference on different aspects of that. Next slide. So for radiation oncology, our limitation is the radiation toxicity. So you can say that we can kill any cancer with radiation. The only problem is we have normal tissue to deal with. And for us, we have a lot of technology, different system. You heard the excellent talk from Dr. Sandhu on the use of SBRT. And I would say that, from all our specialty, we learned about how to deal with side effect toxicity from radiation. And it comes from late acute toxicity, would happen during a treatment and a few months after. And also late toxicity would happen a year or a decade after patients get treated. And you see the list here, and this is the problem we have to deal with and understand, and it limits how we do radiation therapy, and we have to be clever in how to do this. Next. So this is a history of radiation therapy. This is a slide from I got from Dr. Ingradas, and this kind of tells the last 120 plus years of the advanced radiation therapy from early 1900, and since the start of the machine photon from cobalt to the LINAC and CT scan, MRI, and a combination of imaging and all these different radiation modality from cobalt, photon, proton, and carbon. Next slide, please. Yeah. So if I go to talk to my patient nowadays, I have the long list of menu options for my patient, and this can be very extensive, and a consultation can take easily an hour and a half, 2 hours. And so in general, I tell my patient that there are four modalities of radiation therapy. One is active radiation therapy, PBRT, and proton and carbon is one of them. And then the second effect is brachytherapy, where we using radiation active material to put inside the patient in the tumor area or nearby it. And then the systemic radionuclide that we don't use much, that use a label antibody, or some free isotope to treat cancer systemic in a systemic fashion. And then the new one called boron neutron capture therapy, which is another topic by itself, which is very new. And so when we talk about the good and bad radiation therapy, so the good radiation therapy should all go to the tumor and none to the normal tissue or critical organ and cause no side effect. Versus the bad radiation therapy do the opposite, right? So those are the things that we try to deal with. Next slide, please. So for every time with a new technology, there's a question we have to ask: what is better? When we say it's a better technology, so the first thing at radiation oncology we ask in the physics sense, is there an improvement in the dosimetry where the radiation dose can go? Radiation therapy is actually not very specific. We're not like chemo immunotherapy. We target to a certain tumor type, which is target based on where the tumor is and how we get there without hitting the autonomic structure. And the second thing we ask is there any biological effect in the cell differently from radiation therapy? There may be from different type of radiation therapy, but in the majority of time, it's very small. And sometimes we play with it by changing a dose fractionation, like SBRT, we give a bigger dose with different dose low days. We play with the way how they deliver, right? And the third aspect we have is clinical data. Does it make a difference? Does it improve control, or does it reduce side effect? Or sometimes we have both, control and reduce side effect at the same time. And then the next question is how we put into our clinical practice, how we do this. And the last question that now often asked is how much that thing costs, and how effective it is. What the cost effective, what the value of the treatment for the cost of what you can implement to it. Next slide, please. So basically, if you look at biological advantage from radiation therapy and some dose distribution, these are the two things we play with from radiation oncologists, right? So we look at, can we get a dose where it is? And my radiation therapy is different to the tumor cell. So I list there all different types of radiation therapy, different particle. You can see on the axis, it's a photon or X-ray. You can say it's the standard. Just have the standard biological one on the bottom, and you see the IMRT and intensive radiation therapy are very similar, right? But in terms of biological effect, we have all the type of particle, including carbon, medium, hydron, and boron new capture. Those have much more positive effect than X-ray and proton. Next slide, please. Next slide, Sam. So this is how particle beam therapy used around the world. The majority, I would say 80% of it are done by photon. It's in the form of three-conformal IMRT or SBRT. And about 15% done by brachytherapy, and maybe 5% done by simulator therapy. And proton and carbon actually very more percent. In US, only about 2% of cancer patients are treated with proton. And we don't have carbon or beam CT yet. Next slide. So in a very simple picture, you've seen this, the bright proton. What's the point of proton therapy? Just because of the nature of the particle beam, because proton is a hydrogen atom. You have a charge of 1 and it have a mass. So when it travels through matter, it basically didn't lose energy in the beginning. Toward the end of it, it lost all energy and deposit in the radiation called the black peak. And that's what you see here, the example, and we see the X-ray versus the proton. And the advantage of the proton is reducing the exit dose, and hopefully you can reduce the collaboration therapy to a nearby organ. And the proton have slightly more advantage compared to photon, about 10% or 20% more, but that's small compared to other type particle. Next slide. So this is a more comprehensive compare and look at different depth from different energy, electron, photon, neutron, carbon, and in that area. And for a tumor certain depth, the axis on the left is the percent depth dose from radiation, on the right is how far the depth of tumor is. We can adjust the radiation intensity to a tumor by changing energy of proton. Next. So this slide kind of video kind of describe how proton work. But for interest of time, I want to skip it, and it's available for somebody who wants to use it. It's just kind of a simple explanation of how proton work in patient. It may have some delay here, so I'm just skip to the next slide. Next slide, please. Next. So why would you need proton therapy? Why, if you look at the incidence of cancer death in US. This is a slide provided by late Dr. Jim Cox and Dr. Smith for managing cancer before they buy the proton system. In US, there are about 500,000 people die of cancer years. And of those, they break down on the side, head, neck, the GI, gynecological cancer, GU, or different disease side. And from those deaths, they would think how many percent of death are due to local control, right? So the patient dies from local control because surgery is not good enough or radiation therapy is not good enough. Go back to the slide, please. So I think that's the reason why proton therapy new technology needed. Next slide, please. Next. So this is for US, it's about 30 proton center at this time compared to about 2,000 X-ray center in the country. Next slide, please. So I want to kind of show this curve here. This kind of the general understanding for the last 70 years and versus the treatment effectiveness. And on the bottom line, the green line is the progress of photon. And on the top line, the proton therapy. And they both been around since 1950. And you see that up to 2020, the trend from proton and versus X-ray is very close. They're not that whole lot different compared to 20, 30 years ago. Because photon therapy have very advanced in terms of their technology, image guidance, and they're able to track and locate the tumor, and also the way to deliver treatment very effectively with fractionation. But if you look at potential of radiation therapy in the next 10 or 20 years, there's much more potential in particle therapy, in the proton and carbon and CT. So next slide, please. So I want to go over the clinical data for particle therapy in 3 stages. The stage 1 with the first, 1970-90, where the tumor would go to a higher dose because the proton therapy can do it. And the second phase is we try to sparing critical organ and the use of pediatric cancer. And the last stage is now where we talk about we're treating all the disease, all the cancer. We try to push and limit by raising the higher dose, by also sparing normal structure at the same time. Next slide, please. So back in the early day with proton, the disease side that we treat a lot with proton is ocular melanoma, where the patient have to have removed the eyeball, and we treat them with the proton in a few fractions, with a control rate of 95%. And then the basic skull tumor, and we can treat like something like this picture, when you can treat them with proton with a control rate of about 70–90%. And then also where a patient will have cancer near the spinal cord, like spine sarcoma and a large tumor in the pelvic, we only treat with proton therapy. And then a lot from recurrent after radiation therapy. Next slide, please. And this is a sample of the response rate for treatment of basic skull called chordoma, and you see that the old day was taken conformal, and then you look at the green is the fractionated SBI steroid radiation therapy, and the proton therapy when you get to the control rate about 70%, we're using carbon iron, and you control it up to 80–90%. Next slide. Next. So, and then the second phase is the pediatric cancer patient. And this is the case where the kid with rhabdomyosarcoma at the ocular, in the eye area, you can see this. We can treat with proton, and you can spare the brain and the other structure nearby it, and the kid can have a normal life after this. This is something that proton can be very effective for. Next slide, please. And the other one that you see a lot is for treating of cranospinal radiation for merusblastoma, and you see the panel on the left for proton, and in the middle for X-ray, and on the right is for the difference between X-ray and photon. And even though the dose is not very high, but it can cause significant effect on these kids in terms of causing late side effect of cyst cancer, that damage the heart, the bowel, and the brain, other structure area. Next slide, please. And something that's similar to this, we can say that using proton and versus X-ray MRT, even the small amount dose to the bone area, you can see right here, it can affect a lot of kids in terms of their facial structure and other role abnormality. Next slide, please. Next. And this is the data. Go back one slide. So this is the data from the risk of cancer induced by radiation therapy. And this is the data from the pediatric population in terms of all the late complication compared to proton in the yellow, and compare different study from using proton. You can see that different. Next slide. Next slide. Next. Next slide, please. So in phase 3, we now in the US, we have 30 center, and in the world about 100 proton center. And I know there's a few in India. Last year I would have honor to be at the Apollo cancer conclave last year to open front, and I then know a few more open up in India. So now we target a lot of common cancer, and these are lists right here. Next. And I would like to go over some example and of the next phase of proton therapy. Next slide. So for typical treating patient we set up very similar. Next slide, like proton. Next. And for liver cancer, we do, next slide, to do 4D motion, just like lung cancer. Now you look at everything in photon, uncertainty from Dr. Sandhu, uncertainty with proton is magnified to the next level of paranoia. We have to worry much more because it affects the relationship much more. Next slide, please. So we're using motion management. This is what we use called the breath hold system, where similar to other system out there, which basically can watch their breathing and try to hold the breath at a certain threshold. Next slide. And this is how it's patient treated. Next slide, please. Next slide. Next. So we do 3 conformal, we map everything out. Next slide. Into dimension. And we pick the direction the beam come in. So this is a typical case for liver cancer. So we do proton and we treat usually beam from the lateral and posterior, and we use fiducial marker and cone CT scan. Next slide, please. And this is a typical distribution from the proton versus IMRT. With proton, you can spare a lot of low and intermediate radiation doses to the nearby organ of the patient. For liver, the healthy liver, the stomach, and the spinal cord, and the kidney, and the bowel are the major component. Next slide, please. Okay. Next slide. Next slide. And this is a different deviation between the proton and photon. You can see the main one here for the 2 liver. And also you look at the bowel from photon versus very little from proton, and the heart dose versus from photon to proton. Next slide. And this is an example of how proton deliver and 3-dimensional mapping. And then we have patient planning, and usually we treat by using 2-field or 3-field proton and some kind of motion management for patient. And this is how a typical patient treated. And the treatment usually lasts about 5, 10, or 15 fraction regimen. And we use the 15 fraction regimen right now. There's a prospective randomized study in US looking at compare photon versus proton for liver cancer using 5 versus 15 fraction. Next slide, please. Next slide, yeah. So this is some example of the patient treat. Usually the patient I treat for liver cancer, the tumor very big, like 10, 15 cm, in a location that not moving too much. And also they're not adjacent to a critical structure, like this one right here. Next slide, please. And then we typically use a beam that came from the back, from the lateral, that is very stable, we call robust, but that minimize the exit dose to the normal structure. Next slide, please. The next topic I would like to talk about is for breast cancer, which is, for breast cancer treatment are very effective. Patients live a long time. They're often young patients, and they have to deal with a horrible side effect therapy, and the lay effect usually secondary cancer, heart disease, and lung damage. And so the role for proton therapy on this patient is to use radiation therapy to the heart, the lung, and also to better cover the lymphatic and lower those to the surrounding area. Next slide, please. So radiation therapy to the heart can affect the breast because of the blood vessel that you underlie the left breast and the right breast area. Next. And the risk for the effect of the heart, you've seen is the study that every 100 centigrade to the mean heart dose will raise the risk cardiac disease by 7.4%. Next slide. So we can see a sample like typical relation though for the heart on the left side with photon and versus proton, we can have very minimal under, you know, like 20, 30 centigrade to the heart mean heart dose. Next slide. And sometimes we treat patients with recurrent after radiation before. Some of these patients are elderly, they don't want to go back to do a mastectomy. So when 20 some years ago, I used radiotherapy, I put a catheter in the breast and treat this to spare the mastectomy. And now we can do proton and treat the same thing with much less invasive. Next slide, please. And this is another patient that I treat who have radiation therapy before. When he was 30 years old for thymoma, then he had left breast cancer. He's a man. So we try to compare the proton dose on the left versus the photon IMRT on the right side. Next slide. And we can see the dose to the mean heart dose with about 310 centigrade for the photon, and for the heart, for proton it's 1.7 centigrade. And the mean lung dose on the left is also 800 from IMRT versus 4 centigrade for the proton. Next slide. And the patient was treated successfully, and you know, we saw some picture of the skin, you know, basically a few years after. Next slide. And the other case we've seen, the patient have risen before in the chest wall area, they have local recurrent. This is a case where the woman have recurrent a few years after risen before, and with the right chest wall also in the memory node, and we treat them with proton therapy. Next slide. Next slide. And with proton therapy, sometimes you have to pay attention whether we have too much shrinkage. We can have an overshoot radiation therapy in the lung. This case right here, we have to replan the patient to adjust the tumor shrinkage. Next slide. And for lung cancer, you know, we can do the same thing with deliver the same amount of radiation, but we can spare a lot of dose to the heart and the lung area. This is an example of somebody with a very large tumor in the right middle lung area. And you can see the dose to the mean dose to the heart is about 367 versus 1900 for this patient. And we know this patient, they usually have very community with the heart and lung function. So lower dose to the heart and lung make a difference, I think. Next paragraph. And there's a prospective randomized study right now in the US comparing proton versus photon for stage 2 and 3 non-small cell lung cancer. And we also used proton for retreatment of patients who have radiation therapy before. This is a study published by Dr. Chang from Anderson. They're looking at some of the patients treated, and they can give dose about 66 rate in 33 fraction. And they have a very decent local control and fusion survival, you see here. Next paragraph. And this is one of my patients who have elderly man who have non-small cell lung cancer and upper lobe, have chemoradiation therapy for centigrade, and then 2 years after he have a local recurrent, and then he got chemotherapy, and they couldn't take the more to retreat him with proton concurrent with platinum, and he have local control, but he died a couple years later from dysmetastasis. Next paragraph. Next slide, please. So the one thing that about proton is expensive, the cost of the treatment. So I use a 10%, yes, proton is expensive. Yes, proton is costly. But you know, when we look at the cost of a cancer treatment, you have a look not just initial treatment, but the cost of additional cancer retreatment due to cancer recurrent, the cost of life loss due to cancer death, the cost of treatment side effect, and the cost of productivity due to treatment of cancer and side effect combined, right? And those are the things, and the cost of pain and suffering and life enjoyment, right? Next paragraph. Next, please. So to lower cost of proton therapy, we used to do called hyperfractionation. We treat the same cancer with fewer fraction. For example, prostate, instead of treating people with 40, 45 treatment, there's 30, we treat them with 20 fraction or 15 fraction, even 5 fraction. And then with a lot of vendors came out lately, the equipment have reduced a lot. I remember 2 years ago, we spent $90 million for the proton equipment in San Diego. Now we can buy a single room equipment for less than $20 million. And remember, the proton equipment lasts a very long time. The latent activity lasts about 5, 10 years. proton equipment from the one in Loma Linda, I was there for 95, is still functioning after about 40 years of operation, right? And then the facility needs to be efficient and treat more patients, and then we also select the patient better, and then there we come up with new legal application. Next slide. So this is what I'm thinking about the cost difference versus treatment effectiveness, right? So in the worst scenario, we have a treatment that's very expensive but less effective, right? This is the worst scenario. But now with proton, we think that treatment is more expensive, but also more effective in terms of less side effect or more effectiveness. But hopefully in the future, we will to prove that there are certain treatment that can say, maybe we can do a few fraction, fewer treatment, treatment become cheaper and become more effective. In Japan, they treat lung cancer stage 1 with one fraction, one treatment of 36 ray with carbon therapy, and they find out a treatment much less expensive compared to surgery or the standard radiation therapy. That one example. Next paragraph. Next, please. So I think that my conclusion, I think right now we are right here with the 2020, where we see the big improvement from photon actually in the last 20, 30 years. And proton hasn't done much, but I think with the advance of scanning beam, image guidance, and carbon and density, you think there's a lot of potential for particle beam and proton therapy to improve cancer care in the future. And I hope that's a trend we see. Thank you very much.
Thank you very much, sir.
Yeah.
Thank you. Any questions for sir?
Can I ask a question?
Yes.
Dr. Jab, that was an excellent presentation. You know, you showed excellent dosimetric comparison. Now I'm asking, is there data emerging, clinical data, like all the randomized studies for lung cancer and prostate cancer? Where do they stand comparing proton therapy to photon therapy?
Right now, there are 7 prospective randomized studies in US compare photon to proton. So there are 2 for brain, 1 head, neck, 1 for lung. There are 2 G1038 is still accruing, and there are 1 for liver, 1 for breast, and there are 1 for prostate that's completed, and there are 1 more accruing. So we learn a lot in the next 5 years in terms of what patient are benefit from proton and how much is their proton make a difference. And then so we'll see. And I think if you look at the number of clinical trials that for new technology, proton have probably done the most compared to any technology. And you probably don't remember how many studies we have for IMRT versus conformal, right? But for proton, there have been a total of 122 clinical trials. And right now there's 7 prospective randomized trials, 3 in the US. So I think they hopefully will see the data come out in the next 5 years or so, or 10 years for prostate.
The affordability issue, is it there in US also? Because right now in India, if we have to go for proton treatment, it's too costly, and putting up equipment is away from reach of any private payer at least, and government is putting up at 1 or 2 places. But we have our insurance also done by government for public, but that is 5 lakh INR, I think approx $7,000 US, and that's too less for to afford proton treatment. What is your take on technology evolving, and how much for it will take to get equipment at certain cheaper costs?
Yeah, so I think you hit the right point. Equipment and technology is expensive, the value not proven, right? And the X-ray photon got much better. In US, there about 10 years ago, there's a trend for a lot of private investors. They fund big center, including one I work in San Diego. They built a 5-room treatment center, cost $200 million. And all the center went belly up. They bankrupted because you said, the treatment too expensive, insurance stopped covering it, and photon got much better. And then the patient can afford it. So the trend now in US now is most people go with 1-room proton, and they try to buy less expensive equipment. So to give you an example, you can buy a proton equipment for a single room from $50 million versus $20 million, right? And they're not much different in feature. Now, for something like in India, there's a 1.43 billion people there, and there's a small percentage of people that will sit down and look for this technology. And the way you look from that standpoint, that you have to maximize the user machine by, number 1, select the right patient. Number 2, Number two is try to reduce number of fraction. Don't have to treat people with 30-40 fraction prostate. You can do with 5 treatment. Same with breast cancer. Now you see the trial come out, you can do treatment with 5 fraction versus 15 or 20 fraction. If you reduce number of fraction. And then number three, you have to do trial to identify what person benefit the most for your, and then try to utilize the efficiency of the machine to throughput faster. So let's say you can treat patient for 30 minutes or 40 minutes per patient. You can try to change your plan or the workflows they can reduce to 10 or 15 minutes per patient. So let's say you treat a breast cancer patient, you can do one with 3 fields that take you 30-40 minutes, or you can do one with 1 field that can take you 10 minutes. If you do it efficiently enough. So you can improve throughput and select the patient, identify patient that benefit the most, and cut down on the fraction, and find the company that have a technology that's less expensive. And then another thing is you can work with other hospital to share the facility, so you don't have to own it. You can have one that's shared by 2-3 hospitals, and that way you could subsidize the cost.
Yeah. And sir, though I am not going to use protons in my lifetime, I just want, for knowledge sake, I want to ask you, in which sites do you use IMPT, and according to you, in which sites IMPT can be beneficial?
That's a very good question. The first, most data from proton came out passive scatter, almost like 3 conformal photon. So those are the era for the first 1970, 1990, all the way to about year 2000 to 2005. And the last 5-10 years, there's a new form of a photon called IMPT, almost like MRT for photon. Now, there's not much data coming out to do it, but we find that IMPT allow you to sculpt the beam better, just like MRT. You can modify the beam better. But for some selected patient, IMPT is not that good. I'll give you some example. Because of motion and because of the scanning feature of the IMPT, if you're treating a moving tumor, small moving tumor in the lung, on the liver, IMPT is not good. You need the one passive scatter. If you're treating a small tumor in the eye, ocular melanoma, or very close to the critical structure, IMPT is not better than passive scatter. Even not better than some SBRT, because the penumbra or the edge beam is too big, right? So one thing you need to know that IMPT or proton will not substitute all the X-ray IMPT. If you look at the cost of board, only about 20% of the patient have radiation will benefit from proton. 1 out of 5, 20%. And you can pick the site from its disease site, its cancer. You can spend day and day to analyze it. But 80% of patients, they still need treated by the standard radiation therapy, photon. And this is the same true for cyberknife or V-ray or tomotherapy or all the other side. And people only think that you can treat everything with proton. What they do in the United States, just for the insurance purpose, for the money. But in look for the medical necessity standpoint, about 20% of patients are really beneficial with proton therapy.
Over to the chair.
So thanks for the wonderful presentation. As Deepak was telling, we are probably not also going to use proton, maybe in my lifetime also. But it is always good to listen to this nice technology, and good to see that the young kids were highly benefited from such a wonderful treatment like proton. And still, I believe, even not using a proton, it is a blessing for the kids, because for the long-term survival, proton can really make a big difference, which photon cannot do, even with whatever technique we use. But my one question to you is that in carbon, we know that carbon is doing a very good job for multiple times more killing effect than photon. But whether, other than making more conformal dose distribution and higher dose, does it have a superiority in cell killing compared to photon?
Yes, I think you had a point very correctly. Compare carbon to proton. Carbon, they have a much sharper dose distribution, more conformal. Carbon have higher biological killing compared to proton, 3 to 4 times as much. Proton have a 10% or 20% more killing compared to X-ray. Right? Carbon have 3 times that amount. And also carbon also cost twice, 2 times compared to proton. So that's the thing, that right now carbon only available in Asia, like Japan and China, and some Europe, one country in Europe. in Italy and in Germany. But they have plus and minus. And so with carbon therapy, because it's so expensive, much more than proton, that most country now they use it for very selected cancer that very resistant, like GBM or melanoma, head neck recurrent, or sarcoma, and they use a few fraction compared to proton. So with carbon, they use it treat with 15 fraction, 10 fraction, or 5 fraction, 1 fraction. So those are the carbon. And even the US, there are a lot of talk about carbon, but we don't see it yet with another 5 years or 10 years.
Yeah, finally, I want to ask, like Dr. Sandhu, that because in many sites, we don't see a big superiority of proton yet. So what do you think that when we can get a clean cut or discretion that, well, this is the site where you have other than pediatric, in adult cancer, that, well, this is the mature data that will really support that we can get a substantial benefit by going for a proton. Otherwise, if it is equal or very near equal benefit, why to kill somebody for a proton?
Dr. Sandhu, well, I think you have a good point. Like I said, there are 7 prospective randomized trials in the US. Let's take example, one for breast cancer. They plan to enroll 1,700 patients in the trial, compare proton to photon for stage 2, 3 breast cancer. And the whole objective is to prove that proton can reduce cardiac toxicity from 6.5% down to 3.5%. That's what the goal study. It cost $10 million to the study. And it's acquiring about 700 patients, and they see the mean heart rate is reduced from about 3 ray from photon to about 0.5 ray with proton. Would that make different in clinical outcome? We don't know. And the same study done for prostate cancer that been finished. The particle trial from MGH finished this year. We hopefully see some data come out. And the lung study compares it to lung cancer, and from Houston, it's still growing. And head cancer, they see there's some reduced the side effect in oral mucositis and also some swallowing function, the quality of life, and less number of patients admitted to the hospital. So how much those reduce in toxicity translate into practical outcome in terms of adoption and insurance payment and all that stuff, we don't know. And we still learn about proton, even though it's been around for many years. So like I said, surprisingly, the place in the world that have the most proton being developed is actually in Asia. I'm talking about in India, China, and Singapore and those countries right now. There's a more active in terms of new proton center.
Actually, going back to the question, so I mean, the well-established role of protons other than PEDS is in retreatment. So we actually routinely refer patients who've been previously treated and need further treatment for then that's an ideal situation for protons. There's established data for that. But other than that, as Dr. Jap mentioned, there's an ongoing clinical trials. We don't have the outcomes yet, and we'll know in a few years.
So I think, thank you very much. It was wonderful. Both the lecture, was really educational and eye-opening for us. And we have started some of the SBRT proton came to India. Maybe it will be growing faster, and this region people will be getting the benefit of this technology. And end of the day, our cancer patient will be getting the best possible treatment. Thank you very much.
Thank you, my honor.
Thank you, sir. Over to the coordinator.
Yeah, can we start the next session? I would request Dr. Shyam Srivastava, who's radiation oncologist at Apollo Hospital, Navi Mumbai, to start his session. He'll be speaking on managing cancer cervix, the road ahead. I would request Dr. Francis James, radiation oncologist from RCC Kerala, to kindly chair the session, sir.
Thank you, Nikita. I was thinking Dr. Kano Patro is not there.
Sir, he will speak tomorrow, sir. He has some urgent meeting or some of his relative is actually sick.
Okay, that's fine. No problem.
Good evening, Professor Srivastava. Can you hear me?
Yeah, I can hear you, Doctor. I can hear you, Francis.
Professor Shyam Srivastava does not need an introduction. He was our leader as AROI president. So I'm not talking much about, because of shortage time, we'll go ahead with the talk.
Thank you, Francis.
Welcome.
Can you see my slides?
Yes.
Okay.
Yes, sir.
Thank you.
Very well.
Thank you, Francis. I think we are almost 1 hour behind the schedule, so I will just very quickly go through. In next almost 15 minutes, I will try to cover what are the things which have come in the cancer cervix. We have been treating cancer cervix, and especially in India, this is one of the commonest cancer. And there were a few aspects where the studies have been done from the hospital and the part of the India. So those studies that how we have done in this cancer. Now, when you talk about the advances which has happened in the gynecological cancer, especially cancer cervix, we are looking at advances in chemoradiation therapy after the NCI alert came. So there were a lot of issues which came up with the chemoradiation therapy. Then also the newer technology, which is the intensity modulated radiation therapy, image guided IMRT. That was one of the issues that few studies have been done. Is it beneficial? And also the brachytherapy has evolved phenomenally in past few years of time. And the newer avenues with a molecular biology in cancer cervix is also coming up. So I will touch upon each one of the aspects very briefly in that. Now we were knowing that the chemoradiation has been the keystone for the cancer cervix treatment. When we look at the earlier data, there was a lot of data from the various randomized studies, especially 5 randomized studies which have first shown, and the NCI alert came in that. And when we look at the number of cases which were in the late stages, were few in that, nearly less than 30%. So we know that the earlier stages, the chemoradiation was quite helpful. But if in the later stage, the chemoradiation has not been very, very useful, then it is unnecessary. And when we look at, especially in the developing countries and the underdeveloped countries, by adding chemotherapy, if the complications are more, then it will not be very useful. So we conducted one study, randomized study, which was published in JAMA Oncology in 2018, which I'll show you. And another issue was there with for a neoadjuvant chemoradiation therapy for cancer cervix, especially relatively early stage and early 2B, where the parametrium is just immediately involved. And that also a study was published in JCO in 2018. So this was a randomized study, phase 3 randomized study, which was showing the chemoradiation versus radiotherapy alone. And here you can find certainly the chemoradiation therapy has a benefit, especially in the stage 3B cancer. So that has shown, earlier data was showing around 3 to 4% of benefit. While with this study, which is a long-term study and a fairly good number of patients has been taken in this, and that has shown around 9% benefit. So that was the benefit shown. So that was one of the landmark study which was published. Another was there for neoadjuvant chemotherapy. I know with a lot of our surgical colleagues, they wanted to do the surgery for these cases, and especially by reducing the tumor burden by neoadjuvant chemotherapy. And this was unfortunately a relatively the negative study where the neoadjuvant chemoradiation has not shown benefit. So then in these cases, especially relatively early stages cases where 2A, 2B, the chemoradiation therapy being the standard treatment and the surgery do not play important role in these cases, barring maybe a small percentage of patients which can be done. Now with all those, with the advent of the chemotherapy, all those things, we know that we are also looking for various kind of the control rate and also the toxicity. So when you look at these cases with the newer technology that we are looking, and especially adding the chemotherapy, the acute gastrointestinal and hematological toxicity has been the issue, and that has to be addressed. Now, should we do it with the newer technology like IMRT, so that in all cases when the IMRT is being used, will that reduce the toxicity? So there are certain trials in this area, and we have embarked on, especially in the post-operative IMRT for cervical cancer, and also the part we are seeing whether the IMRT will be beneficial in extended field and osteotactic boost. And I'll give you one slide each one for this area. Now, this study was published from the All India Institute of Medical Sciences. Dr. Gandhi has published this data from the IMRT, although the number of patients were relatively small, but that has shown there is a benefit for nearly 50% benefit for the grade 2 toxicity, GI toxicity, and nearly grade 3 toxicity has also been reduced. There was no benefit in the genitourinary toxicity in that. So that has an important aspect. A lot of study with IgIMRT has come, especially in post-operative cases, which is many times is an issue with us. Can you hear me?
Yes, sir, we can hear
Sir,
you.
you're audible,
Okay.
sir.
Okay, right. So that, because there was something popped up on my screen. So this was the study which we have embarked from Tata Mill Hospital. My colleague, Dr. Supriya Chopra has thought about this and started, called it PARSER in a post-operative adjuvant 3D versus IgIMRT. Now, this was also presented in Astro plenary session in 2015. And that has shown that IgIMRT has shown a benefit in these cases. So that by using the IMRT, especially post-operative where the surgery has been done and the poor prognostic signs are there where the patient required chemoradiation therapy, IMRT is quite beneficial in these cases. We also know when we use the IGRT, IMRT in these cases as compared to the 3D conformal radiation therapy, we were looking especially from the Mallinckrodt Institute, from the MEL has published this data where the toxicity, especially when we are using the chemoradiation therapy, the bone marrow toxicity is also seen. So that was also there. And we also had a small study comparing the bone marrow marking here. So whether we are doing the contouring either with a computer based or freehand so that we can compare the what toxicity we are looking for this and can we reduce that toxicity. And various studies are also there with the bone marrow, bowel sparing, bowel spare. This is the Supriya's study which has shown, and there was a reduction in the toxicity when we really take care of the bone marrow as well as the bowel marking in these. Extended field radiation has also been there, but we have not yet analyzed. But obviously, when we look at the dosimetric aspect, certainly there is a benefit when the amount of the intestine that we are radiating is relatively less as compared to other things. So therefore, when we are looking at these treatment, when we are giving the IMRT and or SBRT, this was also thought and many times it was also discussed in the earlier period of time. Can this replace the brachytherapy? And obviously there was a big no in this, and a lot of dosimetric aspect has been done. And this has also shown where the data where the IMRT has come up in the United States, you can see there was a 10% decrease in the use of brachytherapy, and a lot of people started using the SBRT IMRT for cancer cervix. But obviously, when you look at the data as compared to brachytherapy and SBRT IMRT, there is a detrimental effect in the overall survival because this will not be able to really cover the way the brachytherapy covers with the dose, isodose distribution that we see. So there was a decline earlier, but obviously that we can see, and earlier also a lot of things have been discussed about the reimbursement. That was the issue. So that should not be used as a alternative to the brachytherapy. Similarly, when we are looking at the protons, especially the IMPT, and when we are looking at the distribution with the brachytherapy as compared to the IMRT and even the IMPT with the protons, the distribution is not as good as the brachytherapy. So then obviously the brachytherapy plays extremely important role in the treatment of cancer cervix. We also know the doses to the tumor as well as the tumor area, which is there. It is very important, and obviously that has all been shown with the EMBRACE study, and therefore the brachytherapy uses has been extremely important. That how best we can do it, and this has been shown. So therefore, the next EMBRACE study which has have been embarked is the EMBRACE-2. EMBRACE-1 has shown the advantage, and they're limiting the dose to the normal structure like the bladder and the rectum. So EMBRACE-2 has started, which is an international study, an observational study, which is again also seeing the limiting dose to the morbidity with X-ray radiation therapy and the brachytherapy, but also it includes the imaging and part of the biomarkers will also be done in this study. So that is the thing which we can see definitely when we are using the proper brachytherapy and marking it with either the MRI and currently which we can show even something can be seen with the CT scan. Obviously there is a difference in the control. So that is the important aspect when we are doing the brachytherapy, it should be properly done. So that based on this was also a study part of the EMBRACE where we were involved in this. Umesh has published the data and the embarked on the EMBRACE-2, which will, I think the approval has started. So therefore the image-based brachytherapy has been extremely important, and that we have seen over the past few years, there has been a lot of development in the brachytherapy applicators, especially currently when we are using either ring or the ovoids with a central tandem, the addition of these tubes so that medial parametrium can get. Various applicators are there, even the Venezia applicator that you see, which is very versatile. It can go fairly laterally to cover the tumor area. And also, even the 3D printed applicators have also come up where you can, as the geometry is required, that can be done. So these are the various developments in the brachytherapy, and obviously that generally translate into the control rate in these cases. So these were the things, development in the external radiation and the brachytherapy. And the past few years, there have been a lot of interest in finding out the molecular markers which will be helpful in identifying the kind of patients where they're going to either recur or the complication can also be seen. So various markers have been studied. Some of the study which has been done in India, also in Tata Mill Hospital, using the various kind of markers, looking at the stem cell markers. And one of the study which has been published also again by the Supriya, which is for a stem cell marker, and it has shown benefit that if the markers are positive, the survival is better. If they are negative, the survival is poor. So there is a lot of things which can come up over the period of time, which the patient can also be identified, so that possibly you can alter the treatment regimen in these cases so that you get the best control rate. So this is how the things have evolved over the period of time in cancer cervix, and I think a lot of interest has come in the newer development, especially with the acceleration of brachytherapy, and possibly the markers will also be extremely useful in coming period of time. Thank you very much for your patience hearing.
Thank you, Dr. Shah. Any questions for Dr. Shah? Over to the chair.
Thank you, Professor Srivastava, for the excellent talk. He has terrific experience in the past with so many trials, so there is nothing much to add to it. So I don't expect many questions. We are quite interested to find the results of the newer trials running there, including the EMBRACE-2, which we eagerly wait for. Thank you very much.
Thank you.
If there are no questions, we conclude. Thank you.
Thank you, Francis.
Thank you, sir.
Then we move on to the next session. I now request Dr. Kirti Bhushan, surgical oncologist from Mumbai, to share his views on current concepts in colorectal cancers.
Good evening, everyone, and it's an honor and pleasure here, and I'm thankful to Dr. Deepak for inviting me. Can you show me my slides?
Sunidhi, run slides. Okay.
Yeah. So let me come directly to the topic. So today we will be discussing advances in the surgical management of colorectal cancers. See that colorectal cancer is the third most common cancer, and as far as India is concerned, it's 7th in males and females respectively in terms of incidence and mortality. Over the last 10-15 years, so many advances have been done in the biology of understanding the biology of the tumor and the biological behavior. The right side, left side colon cancer, understanding the molecular biology, understanding the pathological aspects of the tumor. These all have led to certain advances and certain refinements in our surgical principles, in our surgical techniques, and with technology adding to it. It has enabled us at present to do surgeries with it has redefined our R0 resection with minimal morbidity and with good disease-free survival and overall survival. The patients are getting better treatment. Next. We are moving from radicality to organ preservation. Minimal invasive procedures are adding to good, minimizing the morbidity. The introduction of laparoscopy and other minimal invasive procedures have added benefit. And we know in number of cases, we know at present how to mix the multimodality treatment, the chemoradiation, surgery for better benefit of the patient. Next. But at the same time, the basics are that we always remove the tumor with a good margin. For transverse colon, descending colon, sigmoid 5 centimeter margin is enough. For right side, we always take bigger margins, large terminal ileum loop and colon. The circumferential margins for rectal cancers, low rectal cancers is 2 millimeter. Distal rectal margins 2 centimeter or even 1 centimeter in selected cases where there is a good tumor biology and less than 1/3 of circumference of tumor is involved. The anastomosis has to be attention free. We prefer a side to side stapled anastomosis, which has almost zero leak rates. And with the introduction of energy devices like harmonics, etc., there has been a decrease in the blood loss in the intraoperative period, and many studies, CRAB, etc., they have shown that less blood loss, better outcome, and or more blood loss has led to the poor outcome. Second, the most important thing while doing the basics is that we need to preserve vital structures which we encounter during the surgery. Next. Apart from these basic things, there are certain things that have come up in the refinement of the, which we say as refinement of surgical techniques, is a complete mesocolic excision. Now, traditionally, surgeons used to remove a tumor, and then if you see D1 or D2 line, that was the line of transection. But now we know that you have to do the tumor. At the same time, you have to do a high central vessel ligation. That will, because that will help us to take as much as mesocolon as possible. Now, what is the advantage of that? Next. You see that once you do a complete mesocolic excision, you end up in taking a bigger specimen, you end up in taking a bigger mesocolon or mesorectum associated with it. Now, advantages of that, next. Various studies have shown that once we do a complete mesocolic excision, the area of mesentery is taken is more, and at the same time, you take the lymph node harvest is more. Next. Now, complete mesocolic excision, what are its benefits is that you do a more thorough lymphadenectomy. This will help in accurate staging, this will help in planning adjuvant treatment, and it has also helped in decreasing the local occurrences, with various studies showing that even it has contributed 5 to 15% range of improvement in the 5-year survival as compared to the standard approach which we used to do previously. Next. Various studies I am running quickly because of lack of time. So you see that the survival 3-year and 5-year survival rates are better with CME as compared to the standard procedures which we used to do previously. These are various pictures. You see the line of resection of complete mesocolon is at the base, at the root where the superior mesenteric or inferior mesenteric artery is giving its blood supply. So you take a time to take a whole of mesocolon. Next. On the right side, you see BD and F. B is the sigmoid colectomy, which is an incomplete surgery, and A is showing a complete sigmoid colectomy with a CME. D is showing right hemicolectomy without CME, and C is showing right radical hemicolectomy with CME. F is showing extended right hemicolectomy without CME, and E is showing right radical hemicolectomy with CME. So specimen speaks up itself. TME next. As far as rectal cancers are concerned, the total mesorectal excision has changed the scenario. You see the bilobed shiny specimen when you do a TME. Next. The idea is to go through a mesorectal plane. You do a sharp dissection under vision in the mesorectal plane. And when you go through a mesorectal plane, there is blood loss is very less, and you tend to preserve the neurovascular bundle also. Next. Again, click. Now, what TME helps is that TME helps in taking a good radial margin, a circumferential margin. You need to have at least 2 millimeter negative circumferential margins, and in locally advanced rectal cancers, especially mid and lower rectal cancers, the TME helps you to take a good radial margin. Next. Another important thing, if you see the dotted line, this is the line of transaction. Now below the line of transaction, you need to go 4 to 5 centimeters below and harvest this mesorectum and skeletonize the rectum. So because studies have shown that you may find isolated tumor deposits within 3 to 4 centimeters distal to the main tumor. So cleaning up that mesorectum is very important. That's why advantage is that it helps you achieve a clear radial margin, and it helps you to decrease local recurrence 8% versus 25 to 25%, 50% when you don't do a TME. Another important thing is that it helps in preserving the nerves, thereby preserving your bladder and sexual dysfunctions as well. Now lymphadenectomy. Next. At least minimum 12 nodes are required for staging. When you do CME, TME with high vessel ligation, we are able to harvest more lymph nodes. And we all know that lymph node ratio is very important. The number of involved lymph nodes, the more lymph node ratio, it helps in the better overall survival. In Japanese also, they do a lateral lymph node dissection in Japan, but for mid and low rectal cancers, but that is still controversial elsewhere. Next. If you see the picture, it's showing the hypogastric nerve, how beautifully it has been preserved in lower rectal cancers when rectal surgery has been done. Next. So the role of sentinel lymph node vessel doesn't change the extent of dissection, but it may help a pathologist and that can upstage a disease in 15 to 18% case. Now you see most of the colon cancers, they have adhesions sometimes with the adjacent structures, and we must avoid tumor spillage by separating the adjacent organ. En bloc resection is favored, and en bloc resections prevent tumor spillage and they prevent recurrences and helps improvement in survival. Next. Sphincter saving surgery. Next. Now we have understood the biology. In rectal cancers, the distal intramural spread beyond 1 centimeter is very rare phenomenon. It is in 4 to 10% cases. Secondly, we have staplers which have enabled us to reach a narrow pelvis and perform the lower rectal anastomosis. Thirdly, you have a pathological frozen section available. So intraoperatively, you can analyze this distal margin during the surgery only and perform oncologically better surgery. Next. So this is a picture showing a stapler anastomosis low rectal. Next. This is the ultra low. You see where surgeon's hands or vision cannot reach, but staplers are reaching, and sphincter saving surgery can be done. Next. Now, to increase the spectrum of sphincter saving surgery, especially in a bulky line, sphincter involved obese males, or there is a pre-sacral adenopathy, this neoadjuvant chemoradiation has extended the spectrum, especially in low-lying rectal cancers. Next. So for any T3 or any T with N1, preoperative chemoradiation is offered. The rationale is it decreases the tumor burden, it sterilizes the margins, it facilitates sphincter saving surgery, and at the same time, it clears the micrometastasis. Next, you see the study showing that preoperative radiation significantly reduces local relapses in locally advanced resectable rectal cancers. Next, even preoperative chemoradiation induces significantly better local control than post-operative chemoradiation without any effect on overall survival. Next. So sphincter saving surgeries can be performed. The number of cases can increase if you give T3 rectal cancer onwards a neoadjuvant chemoradiation. But at the same time, we must understand you must do a sphincter saving surgery in low rectal cancers when it is technically feasible, when it's oncologically safe, and when it is functionally appropriate to do that. Next, minimal invasive colorectal cancers, we have seen that there have been randomized trials which have shown that there is no difference in the oncological outcome in open versus laparoscopic colon cancer surgeries. Next, various trials showing no outcome. However, there is a word of caution for rectal cancers. It has to be very highly selected cases, because many trials have shown that positive or closed margins more in laparoscopy than open surgery for mid and lower rectal cancers. Next, transfemoral endoscopic microsurgery performed by somebody, by many people, but in a number of cases who may not be that fit for the surgery. Next, so for elderly patients unfit for any kind of treatment, tumor is less than 3 centimeter, less than 1/3 of circumference involved, investigations showing no adenopathy, no metastasis, there with a margin of 3 millimeter can be done, but it's technically difficult. There is no nodal dissection done, so it's oncologically unsafe, and lack of long-term results are not there. Robotics has come in a big way in the surgical management of colon and rectal cancers. Next, so it's feasible and safe as compared with open or lap surgeries, but you need to do more randomized control trials to validate its role. There is another aspect of colorectal cancers with liver metastasis. Now, one important thing is that the number and size of the metastasis has no value. Gone are the days when less than 3, more than 3, less than 5, more than 5. The most important thing is that you go for a liver surgery when your primary disease is under control. There is good performance status of a patient. There is no extra abdominal disease, and the liver resection can be done. At the same time, you leave an adequate liver parenchyma for good functioning of the liver. There are various approaches currently, but it's the liver first approach. All the patients who are metastatic, who are unobstructed, it's the systemic chemotherapy you need to start first, because you need to address the liver. You must understand that it's a metastatic disease. But still, there is a traditional approach. Next slide. But still, a traditional approach, doing surgery first, can be done in a number of cases. In cases where there is obstruction, where there is bleeding, where there is perforation, or there is a large tumor where there is impending chance of perforation. So these are the sets of cases where you can have to produce, you have to proceed with surgery first. Second, sequence resections can also be done if patient is fit enough. R0 resection in primary site and adequate hepatic reserves are left. But it's avoided in elderly patients, locally advanced rectal cancers, where or patients requiring major hepatic resections. Now, the idea of the liver first approach is that it kills micrometastasis. It downstages the disease both at the liver and at the primary tumor level, and also it will prognosticate the disease by determining its response to the chemotherapy. The potential simple disadvantage, kindly go back, the potential disadvantage is that it may miss the window of opportunity for resection, because there may be disease progression, or it may be, or sometimes the disease totally disappears in the liver, making it difficult to identify the area of resection. when you want to contemplate surgery. A number of chemotherapeutic, generally FOLFOX or FOLFIRI based regimes are used, and with the addition of EGFR inhibitors, they can help us in a good control by liver first approach. Next. Now, the role of HIPEC is still in a lot of metastatic diseases, in a lot of recurrent diseases. The HIPEC is done by many surgeons. But most important thing while doing HIPEC, we must understand that it works in a low burden tumor, in tumors with good favorable histology, in tumors which have a good disease-free interval, and at the same time, if you are able to do a complete cytoreductive surgery during the surgery. So take-home message is that technical advances have improved outcome. We have moved from radicality to conservative surgeries, neoadjuvant chemoradiation in T3 mid-lower rectal onwards favors sphincter saving surgery. Liver first approach in metastatic colorectal cancers is a good idea. And at the same time, we must not forget our basic things in treating the colorectal cancers as a surgeon. Thank you very much.
Thank you, Dr. Kirti. Any questions for Dr. Kirti Bhushan? Excellent presentation.
Thank you very much.
Moving on to the next session. I would now request Dr. Shamit Chopra, who's Director Head and Neck Microvascular Surgery at Patel Hospital, Jalandhar, to start with the next session. Is Dr. Shamit here?
Yeah, hi Nitika, how are you?
I'm very well, sir. So can we start with the case-based discussion on head and neck cancer, sir?
Absolutely. We'll start right away. And I think I sent a message to Ravindra. Because we're running late, we just want to make sure that we are right on time. So whatever panelists we can see, I'll
make sure, so I'll introduce the panelists we have right now online.
And at the same time, I'll request the panelists. Yeah.
Hello, Dr. Shamit. Welcome. And sorry for the delay.
No problem. We are all there together in this. So great job again. Congratulations.
Thank you. And expert chair also Dr. Pramod Kalsotra is here.
Great. Welcome.
We have Dr. Anil Dhal, who's radiation oncologist from Rohtak. We have
Dr. Vivek Kaushal, expert chair, is also there.
Great. Perfect.
Yes, sir. I'm going to. So we have Dr. Pramod Kalsotra, professor and head Department of ENT at GMC Jammu.
Okay.
Then we have Sir Dr. Shamim Ahmed, who's from Delhi. Then we have Dr. Phub Stering from Bhutan, who's an ENT specialist. Then we have Dr. Manish Gupta, who's a radiation oncologist from Shimla. We have Dr. Ruchir Bhandari, who's a radiation oncologist from Jaipur. And we have Dr. Ritesh Ranjan, who's surgical oncologist from Delhi.
Great. So welcome to all. And at the outset, before I take over from our gracious host, I would request the panelists to unmute themselves, and I'd also request everyone else to mute themselves. Of course, if there are any questions, they can be directed to the chat box. Nitika, will you help me with any questions as they pop up?
Sure, sir. And sir, we have Dr. Vidhu Mahajan also, who's a consultant at GMC Kathua, sir.
Absolutely, great. And I have their names also. And I believe that it's a big panel, and there are a lot of experts. So we may need to make sure that we draw on their expertise at least once. So is my screen visible, Nitika, and am I audible to everyone?
Yes, sir. You're very clear, sir.
Great. So again, welcome all, and on behalf of the organizing committee, it's again a great event, and we are used to attending it. And today we are attending it virtually. I know we have 25 minutes, so it's 9:20 exactly. So 9:45 is the brief given to me so that we finish with the discussion. And I believe the head and neck cancer field is quite vast. So 25 minutes is not enough of a time to do that. So what we
Sir, you can carry on. You can carry on, sir.
Great. So we'll take the questions and a couple of case scenarios. But thank you, Dr. Deepak, for this. And we'll still request you to keep us in check in terms of time, because we don't want anyone to miss their dinner. Okay. Normally you arrange our dinners, but today for a change we'll be having our own dinners. So yes, we want to make sure we're not very late. Among head and neck cancers, we will talk about larynx. The reason I decided that, and the reason Dr. Dhal called me earlier and we exchanged a couple of perspectives, that we'll talk about something that is of common interest to all, kind of common breaking ground, where the functionality of an organ or the complexity of an organ among the head and neck is the highest. And we also want to make sure that that we talk about this slide. This is from Greg Wolf's paper. And you're talking about a scenario where the survival in laryngeal cancer is actually decreased. As we do that and get a chance to welcome my expert chair and my panelists listed on the right, and of course I imagine about 60% of them are available. I think that most of them are radiation oncologists. I think the exceptions are Dr. Mahajan, who's a pathologist, Dr. Pramod Kalsotra, who's of course a head and neck surgeon, and he's also our expert chair today, and Dr. Padam Singh, who's a surgical oncologist head and neck surgeon also. Can you tell me if there's any other specialty here? Should I assume that everyone else is radiation oncology?
Yeah, I'm Dr. Shamim. I'm nuclear medicine physician. I'm associate professor at AIIMS Delhi.
Great, Dr. Shamim. I remember hearing from you, and it's going to be great interacting. So we'll have a question specifically for you as we go. Great. So in larynx, the scenarios that we're going to discuss are these three. We'll talk about something that is of common ground to non-surgical oncologists. And when I say radiation oncologists, I mean clinical oncologists, a lot of oncologists who do give systemic therapy because that's an integral part of organ preservation regimens. And we'll also talk a little bit about moderately advanced. We will, if we get time, we'll talk about early stage glottis, and that's where the war starts in. Maybe everyone can work up an appetite by that time. So moving on. I believe we have some, but feel free among the panelists to put in a comment. The case for you. So this is a patient who's 66 years old and has gynophagia primarily. He has a right neck mass, and what he says, something I want you to pay specific attention to. Drinking water makes him cough slightly. When we examine him in the office, this is the FOL image that we get. So we do a fiber optic laryngoscopy, as all of you do, for your laryngeal cancers. And we see this lesion in the right hemilarynx, and it's occluding or obstructing this area. And what concerns me immediately is the pooling of secretions that you're getting over here. And the description is written right there for you. He has a lymph node on the right side of the neck, and an FNA has already been done, and it shows metastatic squamous cell cancer. So with this, let's go with Dr. Shamim first. What is your radiological modality of choice? Again, I know that I'll ask you a question relevant to your expertise. So what do you think the role is of a PET in disease that is not very advanced, which means we're talking about stage 3 per primum head and neck cancer here. So your quick comments, and then we move on to the definitive surgical oncologist and the medical oncologist.
For PET, the role of PET CT in initial staging of head and neck cancer actually come when there is advanced tumor like stage 3 and stage 4. For the initial staging, actually CT and MRI are still preferred and are recommended by NCC and guideline according to that. But the tumor, those are having stage 3 or stage 4, they are particularly the tumor where PET CT recommended right now.
Okay. So nice encapsulation. For the purpose of the panel and time, I'll encapsulate Dr. Shamim's expertise. Advanced stage cancer, especially one with level 4 and level 5 adenopathy, is one concern because we expect systemic disease. We do, since Dr. Deepak wanted us to talk a little bit about head and neck cancer in general. Nasopharynx and cervical esophagus are two sites where we do use it for initial staging, but of course this discussion is larynx. And moderately advanced or very advanced disease, recurrent disease of course, but in this case, as he correctly pointed out, there is something that is to be made for CT versus MR. So would all the panelists agree that the modality listed at the top, a CT with contrast, would typically be your first investigation of choice in this? Okay, I'll take the silence as a yes answer. You know, there is someone who has probably mute his mic because I think we can hear some extraneous noises there. So maybe Ravindra can find out, and maybe
I think everybody please mute their mics, and only the question you direct the question to should open the mic.
Perfect. I can't see all the panelists in the grid because I need to see my slide as well. But I'll keep on directing.
Ravindra, please show in a grid.
Great.
Ravindra or Sunidhi, please show panelists in grid.
Okay. So CT features suggestive of cartilage involvement and extralaryngeal spread are by now known well. I think I heard from a couple of panelists in the interim that they would also prefer a CT. So that remains our investigation of choice for detecting moderately advanced disease in larynx, by which we mean that disease which typically has a chance of eroding the cartilage or going outside the confines of the larynx, which are usually very well-defined confines. In terms of sclerosis, cartilage erosion, extralaryngeal spread, we know that the CT also has limitations, but having said that, in most of our practices, because of spatial availability, because of the spatial resolution, the speed, and the relatively low cost and availability, we end up using the CT much more often than not. Remember, and this is for the trainees, that in case you are doing a CT, you have to order spiral contiguous sequences, fine cuts through the larynx to pick up that subtle focus of cartilage erosion or extralaryngeal spread. And you always want a contrast enhanced CT. You also want to assess your lymph nodes when you do that.
Dr. Shamit?
Yes, absolutely. Please go ahead.
There's one point. For MRI of the neck, there's a deglutition artifact. So yes. I think CT is still better than the MRI.
Absolutely, sir. And again, welcome. And it's good to see you in great health and good spirits. And we haven't seen each other in a while, but yes, hopefully that will change very soon. So for CT, when we evaluate these patients, and remember, this is one case vignette that I put forward for you, we do use the MRI selectively, like Dr. Kalsotra pointed out. The MR essentially is used like a problem-solving tool. So if the CT shows equivocal changes, there is an extremely elderly gentleman and you're not really sure if variable patterns of ossification versus cancer are going on, in that case, you use it. So in this case, for instance, we're just showing you one slide each, and there's a right hemilaryngeal lesion. This is not our patient, this is just a different patient. But when you do an MR, because you think equivocal cartilage erosion might be, you find significant extralaryngeal spread and you find erosion of the inner cortex as well. So message to everyone, especially the trainees and the early practitioners in oncology, CT is usually the initial investigation of choice for larynx, and you use the MRI as a problem-solving tool if you are concerned about certain features, or if your radiologist or your tumor board is concerned about whether or not the patient has cartilage erosion or extralaryngeal spread. As Dr. Shamim pointed out, PET in very select indications, but then again, initial investigation will be CT in the vast majority of circumstances of your larynx. So coming to our patient, and again, we don't have a radiologist on the panel, I believe, but I'll ask any one of the radiation oncologists to take a call on how the next modality is going to be. So we got a CT neck and chest in this patient, and pretty much the examination was corroborative with the CT, barring radiology only features like pre-epiglottic and paraglottic spaces which were involved, and the lymph node that we talked about, which was initially about 2 centimeters on clinical examination. Remember, there are studies done that sometimes we feel the node through the draped SCM. So we may end up over assessing that lesion. It's actually a slightly smaller lymph node. It's about 1.5 centimeters involving level 2A lymph nodes. And that's again one of the primary echelon. And the CT thorax is negative. So does Dr. Ruchir, I see Dr. Ruchir over there. Hi, how are you? Good evening. So, and he can unmute himself probably. I think like Dr. Deepak pointed out, it's a good idea if all of us unmute ourselves in case we have to answer. Can Dr. Ruchir hear me? Okay. Any of the panelists want to take the next question? And the question is that if you have disease like this, and for the sake of proceeding well in time, we'll talk about it being a T3N1 disease as is proven by radiology, and of course M0. Do you do routine evaluation of dysphagia in cancer involving the supraglottis like this one, or the hypopharynx where it's reaching up to? Maybe Dr. Pramod can give us expert views on that. Sir, would you do dysphagia evaluation in this kind of cancer?
No, we don't do any routine dysphagia workup in these patients. We simply go for endoscopy biopsy.
Okay, great. Okay, so the 3 evaluations for dysphagia in a patient like this would be these. As Dr. Pramod pointed out, there is going to be some role for, let's say, doing a trial water swallow test. However, it is limited. The reason that routine evaluation of dysphagia is now becoming a little more widespread applicability, or maybe some centers would do it as opposed to otherwise, is because of the low sensitivity and specificity of the initial testing that we talked about. So in the past, the standard teaching used to be that if you have to decide in a stage 3 carcinoma larynx, whether or not you have to do organ preservation surgically, non-surgically, or not do organ preservation, you should first find out if the patient is aspirating. But as you can see, the sensitivity and the specificity of a trial water swallow test is quite low. Since it is low to that extent, which is why the philosophy has come by of supplementing your office exam with some endoscopy-based systems, like Dr. Pramod pointed out. Should we do questionnaire-based evaluation of dysphagia? Should we do endoscopic evaluation of dysphagia? Should we do fluoroscopic? Especially in these patients where he's telling you that drinking water makes him cough slightly. Does anyone in the panel want to take this question? And the question is routine evaluation of dysphagia or aspiration in a patient who's presented to you with this kind of tumor. Dr. Dhal, would you want to address that, please?
I think they have muted themselves now.
Hello.
Yeah. So can you get them requested, Dr. Deepak, for the panelists to unmute themselves?
Ravinder?
All panelists should unmute themselves.
Ravinder and Sunidhi.
Sir, we have given access to all for unmute.
Okay.
Sir, ideally we should, in this patient, we should be doing it, but routinely in most of the centers and including ours, we are getting endoscopy done and then proceeding further.
Okay, great. And who was this? I'm sorry, I cannot see.
Manish, Dr. Manish from Shimla.
Oh, great, Dr. Manish. Hi, how are you? So again, astute comments. You know, we are one of those centers which have tried to look a little bit into it. And there are 3 ways of looking at it. And we've looked at all 3 ways. We've looked at questionnaire-based dysphagia, and the 2 which we've studied, and incidentally, it got published in the Red Journal of Radiation Oncology. We looked at MD Anderson as well as E10, but that was in a different subset of patients, not laryngeal cancer. Having said that, we started extrapolating these findings. This is the E10 questionnaire. This is from our alma mater in California. And it's an easy tool. And whenever the dysphagia evaluation is more than 3 per 40, we generally move on to a more detailed scale, like the MD Anderson dysphagia inventory. Now, this is more time consuming. It's not very effective in a very crowded OPD, which is why we do it as secondary screening. So E10 is a good questionnaire. They don't need any instruction in it. They can just read the vernacular questions and then go by it. Since Dr. Manish commented on that, what's your experience been with endoscopy-based evaluation of dysphagia? You mentioned that we do an endoscopy. Of course, we have to do it in every laryngeal cancer patient. But have you tried incorporating anything else like a FEAS or a functional evaluation of swallowing? Maybe asked your surgical colleagues to do that.
We ask, but most of the time it is not done actually.
Okay.
We do ask, and one of the thesis was there in our department. It was with regards to actually esophagus upper 1/3.
Okay.
So we had done that in that case, but not in all the patients.
But I congratulate you for taking up it as a candidate thesis, because it's really something which is evolving, and which is why we have the expertise of a lot of expert panelists. So we wanted to draw on our experience and also share with you whether or not people from the region and across the country would be doing that. Dr. Dhal, I see is not unmuted yet.
Dr. Shamit, sorry for interruption.
Yes.
We have a very senior radiation oncologist, Professor Dr. Vivek Kaushal, who is expert chair, and he can also contribute.
No, of course. I did not see Professor Kaushal. Welcome, Professor Kaushal. I hope you're doing well. And we'll probably draw on your expertise in the management part of this. But maybe currently we can probably draw Ruchir. I see Ruchir is unmuted. Ruchir, can you hear me?
Yes.
Yeah, great. So
yes, Dr. Shamit.
Yeah, could you help us establish? Now we've decided, or we are talking about probably pushing the envelope in a patient with intermediate stage cancer who's giving you a history of coughing slightly. We know trial of water test is not very reliable, and we're looking for a test which can help us find out whether or not the patient is aspirating. If the patient is aspirating, he's a candidate. He's not a candidate for organ preservation, surgical or non-surgical. And if he's not aspirating, he's a candidate more for non-surgical than for surgical. Can you help us find the difference between these terms? What penetration, aspiration, and silent aspiration? Do you use that in your practice?
Well, I've been using aspiration and silent aspiration in my practice.
Okay.
The aspiration is when the patient is giving complaints of coughing during swallowing. And silent aspiration is when we do a chest X-ray or a CT scan of thorax and we see findings like the one which is shown in the below picture.
Sure.
That is silent aspiration.
Good.
Penetration, I'm not very sure of.
Yeah, sure. So penetration is above the level of the vocal cords, but again, that is more from a laryngologist perspective. But yes, aspiration, as you mentioned, is what we have to look for. Patients who are not aspirating will typically be candidates for non-surgical organ preservation or even surgical organ preservation, not in this patient, but in select subsets. So what we've done is, like Dr. Pramod mentioned, we have to do an endoscopy. Dr. Manish mentioned we have to do an endoscopy. We've tried incorporating endoscopy with something called a FEAS, which is a very widespread tool now these days for neurological dysphagia, and for oncological dysphagia, we use that equally well now. It's done at the same time. We do it with 3 boluses. There are 3 positions, and as you can see, this is our patient. This is the central picture of our patient, and he is not aspirating, which means, as Dr. Ruchir pointed out, this patient does not have a bolus going inside. There is staining of the posterior pharyngeal wall. There is some pooling like we found in the video as well. But for the most part, the food bolus, the colored food bolus, is going by this side. This is something that does not entail any additional cost to the patient. And again, entails maybe a cost of about 15 or 20 rupees to the hospital. So we don't charge our patients extra for that. But all laryngeal hypopharyngeal cancer patients will typically receive this, especially if they are in the marginal zone like this patient is. Any comments on FEAS? Any experience with FEAS that any of our expert panelists would want to share? Okay. So we've talked about questionnaire based. We've talked about endoscopy based. This is something that's considered the gold standard for aspiration, and that is video fluoroscopy. We know that swallowing has 3 phases: oral, pharyngeal, and esophageal, and there are a lot of parameters of the video fluoroscopy. And this is what we did in our patient actually. The FEAS is something which is limited by a swallowing whiteout, but this patient will typically get a video fluoroscopy to confirm whether or not the patient has aspiration. As you can see, this is some trazograph that is mixed with a liquid food bolus in different consistencies. And you can see the 3 phases of swallowing as are pointed out by these stills. And after that, you'll see a real-time image. So this kind of patient is typically someone who gets bolus inside his mouth. You can see that. And then he initiates the oral phase, the preparatory, the propulsive, the pharyngeal, and there's some staining, but you can see this patient is not aspirating. So this is our patient, and we are now dealing with a situation in which we have clinically staged him, radiologically staged him, and as is the norm these days, we have also functionally staged him. So he is a T3N1M0 squamous cell carcinoma of the marginal zone. That's the term that a lot of head and neck surgeons use in terms of the boundary between the hypopharynx and the lateral wall of the larynx, which is the arytenoid AE fold and the medial wall of PFS. And of course, the functional staging says that it's a functional larynx. So we'll call on the expertise of our expert chair, Dr. Kaushal, if he's still here, of the 3 options that we have currently. This patient, a T3N1 functional larynx.
The treatment of choice in this patient would be radiation plus systemic chemotherapy.
Perfect.
Because the meta-analysis has shown that that could be a better option than neoadjuvant systemic chemotherapy or surgery followed by radiation therapy, because surgery loses the function of the organ.
Yeah. So was that Dr. Kaushal? I'm sorry, I didn't get your picture.
So radiation plus first option is the best option.
Great.
Radiation plus systemic chemotherapy.
So we've already heard from the chair, and
I do agree with Professor Kaushal that as for RTOG 9111 trial, these 3 options which you have shown on the screen, they were all explored. And out of these 3, like induction or RT alone and CRT was the best, keeping in view the local control rate, which was higher among all the 3 arms.
So I'm glad Dr. Dhal can almost read my mind. This is RTOG 9111. And we talked about these 3, and he hit the nail on the head. I could not explain it better than him. There were 3 arms, and most importantly, loco-regional control was better, intact larynx was better, and suppression of distant metastasis was better. And what's even more important is that they did an updated results, as all of us are aware of, and over 10 years, these findings have remained consistent on long-term follow-up. So functional larynx, which is not moderately advanced, is typically treated with non-surgical organ preservation, as most of you would agree. However, there are some studies that are coming up on large volume disease, volume playing a role, and there's still a while before they catch up. When they do, we are in for a very interesting time, because at that time, the discussions will probably move a little bit more. there are some biological indicators of selection of organ preservation therapy also. And again, we'll be looking forward to that data. But currently, this is the best we have for this kind of patient. So, do all the panelists agree they'll do radiation plus systemic therapy for this patient?
Yes, definitely.
Okay, great. So, Dr. Manish, since we have you online, kindly tell me, and again, it's all Greek to me, and you have to be glad that a surgical oncologist is actually advocating this, because it's more evidence-based treatment. But tell me, what is your opinion on the dose and fields, and then we'll ask the rest of the radiation oncology experts whether or not they agree with it for this patient.
We'll go till 66 gray in 33 fractions. And because we are not using IMRT here, so I will be telling about the conventional radiation, and that will be 3-field technique. And the fractionation will be 2 gray per fraction, 5 fractions per week. That is what we are going to do, along with weekly chemotherapy on every Monday, 40 milligram per meter square.
Okay. Does anyone in the panel among the non-surgical oncologists have a different opinion for this patient?
I want to add, Dr. Shamit, if you allow.
Yes, yes.
Okay, basically, sir is absolutely right about the conventional regimes. They are usually up to 64 to 70 gray, but as per the NCCN guidelines, the accelerated radiation protocols, they have shown the better results, particularly the 2 options. One includes the concomitant boost accelerated RT, in which we give 1.8 gray as initially, and followed by the last 2 weeks time we add up 1.2 gray, or the hyperfractionation 1.2 gray as a twice daily regime. They have shown the better results as compared to the conventional regime.
You know, again, like this would be like carrying coals to Newcastle. I would not speak with expertise about radiation in a panel of radiation oncologists. But is that the practice that you follow at your institution?
Normally, we follow the conventional regime protocol, which is 64 to 66 gray in 32 to 33 fractions.
So maybe we can have Dr. Vivek Kaushal, our expert radiation oncology chair, and then we'll draw on the experience of our expert surgical oncology chair later. But Dr. Kaushal, would you agree with the fact that conventional fractionation should be considered standard of care, especially
whatever our doctor?
I think we lost him. Can everyone else hear me?
Yeah, we can hear you.
Yeah, okay. So I think while Sir comes back, and we'll ask him that question later as soon as he rejoins us. But it seems to me, from the opinion of Dr. Dhal and Dr. Gupta, that you...
Can you hear me?
Yeah. Yeah, can we again?
Yes, sir, we can hear you.
Yeah.
The volume of the disease, and in this case, we would be giving 66 gray in 33 fractions.
Okay, I think 66 and 33 seems to be emerging as a consensus for this. I think Dr. Dhal also mentioned 64 to 70. So we'll take it, in the interest of time, we'll take it as 66 grays and 33 fractions. And of course, we talked about conventional fractionation, more or less. And of course, the fields are something that are entirely your domain. So I'll defer to you as a surgical oncologist after discussing it with you in the tumor board. Coming to systemic therapy, I believe there was some comment made about 40 milligram per meter square. What is your protocol? Does someone want to take this in this patient? And this patient, remember, is a 66-year-old. I'll share his creatinine. His creatinine is about 1.3. He is otherwise good PA, does not have any other comorbidities. Would anyone consider 3 weekly cisplatin in him?
Yeah, that is the category 1 recommendation, that we have to give cisplatin 100 milligram per meter square on 3 weekly basis, means thrice during the whole radiation protocol.
Yeah, so we now see about 1100 new head and neck cancer patients at our institution. About 30 to 40% of them would typically get upfront surgical, non-surgical organ preservation. And we've looked at this. About 25% of our patients will get 3 weekly cisplatin, but that there's always a selection bias, right? We always select the fitter patients, good creatinine clearance, non-comorbid patients, relatively younger patients. I agree with you and the comment that was made earlier that weekly regimens would probably be preferred a little more in this patient. And we've looked at data from India. We've looked at Amrita data. We've looked at Tata, Vanita Naronia's data. And we know that weekly is probably inferior. But yes, because of the unique conditions in which our patients are, the fact that they are baseline dehydrated, the fact that they are baseline nephropath, probably there is a point to be made for weekly chemotherapy. So definitely weekly cisplatin has a role to play. Dr. Dhal mentioned the recommendations. These are the current guidelines. It's a category 1 recommendation. Having said that, weekly cisplatin has made it now as a category 2B recommendation. And it is something that you'd be well within your rights to give, especially if you're concerned about long-term toxicity to a patient, in which radiation and chemotherapy cumulatively will have toxicity. And we know about MACTA's meta-analysis and the long-term toxicity of the same. So it's a fair assessment that most of you would consider this patient for weekly cisplatin. But yes, if he were absolutely fit and if he had a good creatinine clearance, let's forget about the 1.3 for a while, then you would probably select a minor subset of these patients for 3 weekly chemotherapy. Would that be a correct assessment?
Yes, definitely. Yes. And
3 weekly regimen, it has got an advantage that it is a very easy given in a busy center. So when you give a weekly regimen, then you turn patient and you got a low
and everything, when all of us are grappling with available beds in a situation when half the beds or a fixed percentage of our beds is designated for non-oncology patients, it becomes a very important consideration. So I really appreciate your comments for that. One point, targeted agents and immunotherapy were correctly not pointed out by the expert panel as being an initial option, even though they are category 1 guidelines also. Just one point I wanted to make from Warner's trial, and look at the red boxes. When we look at prolongation of loco-regional control, and we look at prolongation of overall survival, see that larynx and hypopharynx really did not have much of a benefit. Larynx and oropharynx was predominantly the one that was driving the game. Oropharynx was the one with a better hazard ratio. But when you look at larynx and hypopharynx, especially when you're talking about treating our index patient, probably cetuximab anyway is probably not the best way to go. Like our experts have pointed out, if your patient is a candidate for 3 weekly, do consider it. If your patient is not a candidate for 3 weekly, at that time, by all means, consider weekly cisplatin. It's now a category 2B recommendation, or consider other platinum agents or the other regimens that you're comfortable with. Cetuximab for larynx hypopharynx in initial setting of definitive organ preservation is probably not the best option based on this data from the landmark trial that all of us see, because oropharynx was probably driving the survival. And that's just a point before we move on to the next case. Does anyone have any comments before we move on to the next case about this particular patient, T3N1 disease? Any other thing that you have done, any modifications or tweaking in treatment that you want to probably add? Okay, great. So we'll take it as a consensus, and that's a successful first case. Everyone agrees with each other. So we'll talk about the next.
Can I? Shamit?
Yes, sir. Absolutely.
If this case is T3N2 M0.
Yes, sir.
Then what's your protocol?
It's a very interesting question, and I'll probably throw hornet's nest hat by saying, if it were N2A disease, or if the nodes are more than 3 centimeters and have a necrotic hypoxic center, then I would probably treat this patient with an upfront neck dissection, which is virtually outpatient in our center, and then send our patient to our colleagues in radiation and medical oncology for doing non-surgical organ preservation to the primary. However, if the N2 disease is N2C and small volume on both sides, 1.5 centimeters on both sides, and both sides are positive, in that case, I would probably, if the nodes were in level 4 and 5, like we talked earlier, I'd probably do a PET for initial staging. If that patient is systemically negative, then in that case, I would probably consider his presentation in tumor board. Most likely in our center, he'll still get chemoradiation, but there is a case to be made for induction chemotherapy in large volume disease.
Okay. Yeah, thanks.
Yeah, great. So, you know, I'm glad Dr. Pramod asked me that question, because we have to move a little bit more towards the other stream of oncology as well. And, you know, we'll discuss, my point was initially that we'll only discuss 2 cases, and of course we'll let Deepak abbreviate us as whenever we go along. But this case is an interesting counterpoint to what we just discussed right now. This is a 65-year-old female, starts off with dysphagia, dysphonia, shortness of breath, but one line, and we like putting one line for our patient comments, it all started with an earache. And teachers for multiple decades, like Professor would probably tell us that that indicates that the disease is more advanced. It's involving cartilage. It's involving the tympanic branch of the glossopharyngeal nerve. But moving on, this patient had a tracheotomy and a biopsy at an outside center for shortness of breath, and it showed moderately differentiated squamous cell cancer. We'll show you the video. We'll show you the video of this CT. And as you can see, this patient has an extensive disease, and there's no question about whether or not the patient has extralaryngeal spread. It's virtually touching the carotid. The cartilage is destroyed, and you can see a representative image over there, and you can see an endoscopic image there, and we use some narrowband imaging also, as you can visualize over here. And therein, we end up getting a patient who has moderately advanced cancer. CT neck and chest were again done. And again, this is one case in which, like Dr. Shamim pointed out, a PET CT could have been an option. We have one at our institution. For some reason, don't recollect, it's a while back, this patient got a CT neck and chest, which is adequate staging. We've done a cohort study of about 700 odd head neck cancer patients and their metastatic patterns. The CT chest is usually sufficient for larynx hypopharynx cancer. The patient has level 2A and 3 adenopathy, which is probably why we did not do a PET CT for initial staging. And the patient is now staged based on the information that we have as a T4A, N2B, M0 laryngeal cancer. Now, any other questions that any panelist wants to know before we start talking about management? Functional assessment, of course, we already know it's a non-functional larynx. The patient is tracheotomized. So tracheotomy, aphonia, and aspiration are the 3 criteria. Again, for the trainees, simple words and simple criteria. Aphonia, aspiration, tracheotomy dependence, 3 criteria for a non-functional larynx. This patient has a tracheotomy dependence. So we did not test for aspiration because we thought there was no role of functional evaluation in this case. Okay. So we'll move on, and Dr. Manish can probably answer that because I see the yellow bar is around his name. Dr. Manish, what constitutes moderately advanced laryngeal hypopharyngeal cancer? And by essentially we're talking about T4A disease over.
Whether it is surgical resectable or not, that will decide basically. If you have shown it on the slide actually.
Yeah. So again, moderately advanced is usually T4A. Very locally advanced is T4B. So the point that Dr. Manish made, it's very important. So I'll re-stress it for reiteration's sake, especially for our trainees and early practitioners. You want to dissociate your T4As from your T4Bs. T4B, which essentially is encasement of carotid artery, involvement of the gross involvement of the prevertebral fascia, involvement of the mediastinum are typically T4B candidates. But this patient, like we talked about, again, for the interest of time and to abbreviate it, we're talking about T4A disease, which is large volume. And again, 9111 comes in, and it's interesting because this is a counterpoint to what they did for patient selection. Note on the red side that they did not consider large volume T4 disease for organ preservation. And this is at the time that they initially selected their patients. The 500 odd patients that they took had a small percentage of T4 tumors, a very small percentage, as you can see in that table of T stage, and patients who had gross involvement of base of tongue musculature or involvement through the cartilage was not considered eligible. So RTOG 9111 does not apply to this subset of patients. Okay. Also, what we know from another widely quoted study from Adelstein et al. That 54% of patients with stage 3 and stage 4, and again, a lot of those were larynx, failed at the primary site, and 63% were salvaged successfully. So the conclusion that the authors had was at the bottom of the slide, that a large primary site treated with aggressive chemotherapy and radiation still may result in functional impairment and negate the value of any organ preservation achieved. So what it means is, you preserve the organ, but you preserve a functional organ. There is no point preserving a dysfunctional or non-functioning organ. You will give them a lifetime of aspiration and stenosis. So again, surgical as well as non-surgical PIs have typically pointed out to that. Any comments on these two papers for Astier and Adelstein? Anyone who wants to talk about it, and anyone who disagrees with the thought that this larynx should be preserved in this patient? Okay, so moving on, if you look at the classic induction trials, we talked about chemoradiation, we've ruled that out for this patient in the upfront setting. Of course, there's a role in adjuvant, and we'll probably drive on the expert opinions of all our panelists. But if you look at chemoradiation, we talked about the fact that it's not a viable option. If you look at induction chemotherapy, there are again two counterpoints. The original VA study, 56% of T4 patients needed a salvage laryngectomy versus about a third of T1 to T3. So which means that even the landmark induction trials have really only focused on low volume T4 or smaller disease to achieve that endpoint of organ preservation with no significant difference in overall survival. When you look at more recent data on induction chemotherapy, again, that ceases to be an option in our patients for the large reason of toxicity. I think someone mentioned among the panel that we are looking at a subset of patients where toxicity is a concern. And yes, the reason we select our patients, or there is a selection bias, is because we do have toxicity concerns, especially in the country that we live in and the patients that we see. So even if you look at TAX 324, which is one champion trial for neoadjuvant chemotherapy and really has dictated a lot of our practice patterns, 68% patients could not complete the full dose regimen, and looking at 90% patients with grade 3 or 4 toxicity. That in light of the fact that chemoradiation induction chemotherapy are ruled out, and the simple fact that you want to not preserve a non-functional organ, is the reason why guidelines recommend upfront surgical management as initial therapy. And this is what the NCCN says. And again, this is what driven into sites and subsites. And there are roles for category 3 guidelines where hypopharynx T4A could be given induction chemotherapy, but surgery and neck dissection is still considered standard because it's category 2B according to NCCN. And in supraglottis and glottis, there is no confusion. In subglottis, it's not mentioned, but since, again, as a head and neck surgical oncologist, I'll share that there are very few primary subglottic tumors. Most glottic tumors, most subglottic tumors are actually extensions from the glottis. Dr. Kulsotra, do you agree with this? Primary subglottic, very few, right?
Yes, very true.
Okay, great.
Primary subglottis is very, very rare.
Great. So we are dealing with 3 subsites: supraglottis, glottis, and hypopharynx. And if you look at guidelines for our patient who has a non-functioning larynx, normally a laryngectomy would be considered standard of care. A partial laryngectomy is not an option because of the location of this disease. But yes, in some select patients with low volume T4 disease, where surgery might be considered standard of care, partial laryngectomies can be done. But coming back to this patient, a laryngectomy is feasible for advanced glottic cancer, and we can sometimes get something that we call a primary closure. Since I realize that a lot of us are non-surgical oncologists in the panel and the audience, I'll just quickly skip through. But do remember that if you are doing it, if any one of you has had the expertise of treating a patient that we get as surgical oncologists later, we end up having the defects of the skin, there are ways with current reconstruction that we can take care of that. And flaps are something that are used. Flaps are also used for these kind of defects, where the laryngectomy has been done for T4A tumors and depending on subsite. And usually in this age of microvascular as well as pedicle reconstruction, we are able to do that. So our patient is the one on the right. This defect is something which goes from the base of tongue to the cervical esophagus. It's a complete defect. You have carotid on the left and you only have one jugular on the right. So this defect is something that has to be addressed, of course, so that we are able to give a patient, we promise them good function, and we have to make sure that we give it to them. And the flap and the reconstruction is based on a combination of patient factors and tumor factors. And these are factors, again, this will be something I'll probably mail to my surgical colleagues in case Dr. Pramod has a comment. Go ahead, sir.
What about your neck dissection in this patient?
So normally, sir, larynx, we now know that levels 2 through 5, if level 1 is not involved, is considered adequate for a positive neck in the larynx, and 2 through 4 is good in the elective setting, as long as we do a level 6 neck dissection along with. So to answer your question even more lucidly and briefly, elective 2 through 4 with 6, because 6 has to be done along with any larynx. And in a positive setting, if level 1 is involved, then 1, 2, 3, 4, 5 on the same side. But normally these tumors will need a bilateral neck dissection, 1 elective, 1 modified, and so on and so forth. These days, level 1 is infrequently addressed. And for a lot of positive necks, we spare the patients the marginal mandibular morbidity and the morbidity of removing their submandibular glands. That way, we can probably make sure that they have lesser incidence of xerostomia, and we are also able to spare level 1 per se. And the survival rates are roughly comparable. Okay, I'll skip through this very quickly, but just to make a point that free flaps are typically something that are used.
Shamit, sorry to disturb you. There was an international faculty in your panel, Dr. Fubchering. Is he here? I think we haven't involved him.
Yeah, you know, I like just thank you for reminding me, and keep on telling me if there's anyone else that I need to engage the expertise of. The people I'm seeing on my thing, because of frequency of usage, are probably the ones that we are driving on. But
Dr. Fubchering, are you here?
If he's there, we'd like to hear from him, of course.
He left 5 minutes back, sir.
Okay. So yeah, you know, my personal apologies. I did not see him here, and again in the large group of 15 panelists and 2 expert faculty, I have to be excused for not seeing a couple of people, because I'm only seeing the tiles of 6 people currently. So just driving the point home that free flaps have high subjective satisfaction, pliability, reliability, and generally have a low fistula rate. Dr. Kalsotra and I think Dr. Padam Singh was also supposed to be there. Since you're mentioning that, Dr. Deepak, I'm just wondering if any other surgeon is there in the panel.
No, he is not there, but Fubchering was there.
Okay, was he a surgical oncologist?
He was an ENT surgeon.
Oh, so that's great, because we did not get designations in our moderator brief.
Maybe can you please connect him?
Yeah, if you can connect him, I want to ask him this question.
Will you please connect him on his personal number or email?
Sure.
We'll wait for him to join us. Until that time, I will till that time I will ask again Professor Kalsotra as to whether he uses salivary bypass in any of his laryngectomies.
No, we are not doing salivary bypass right now.
Yeah. So
one more thing, we are not doing microvascular in this setting. We are simply using pachymeasure for this sphere.
Yeah. Again, fair enough, sir. Again, it depends on institution to institution. We found free flaps to be a little more beneficial than we do circumferential, and that way we can give our radiation colleagues maybe a relatively early start. That is one of the advantages that we listed, and our patients can swallow a little, because it becomes very difficult to get the inferior ring. Also, pectoralis major in our series and most other series is predisposed to a higher fistula rate, especially inferiorly or at the base of tongue, because it's gravity and the residual neogullet might be aphonic. So we might not be able to restore this for them. So this is our patient. Our patient got a radial forearm free flap for circumferential reconstruction. You can see this flap that is open and will be closed subsequently. You're seeing a salivary bypass tube inside. This patient, you can see the microvascular anastomosis on the lower side. He was discharged on PO day 6. She was discharged on PO day 6 with stable surgical site. And the final histopathology, and we'll have Dr. Kaushal comment on how he would want to treat.
Shabir, there one question from me.
Yeah, I'm sorry.
One question from me, please.
The locally advanced supraglottic and glottic cancer. Can you hear me?
Yeah. Kindly introduce yourself.
It's Dr. Kaushal.
Okay. Yeah, doctor.
Hello?
Please go ahead.
Okay. About the locally advanced glottic and supraglottic cancer, what we do is we start the patient on concomitant radiation, and then these patients, they self-select themselves. 1/3 of the patients will complete the treatment without any problem. 2/3 of the patients would have interruptions in between. And when they'll have interruptions in between, their body or the patient's body is going to self-select how much radiation and chemotherapy they can tolerate. In some cases, it would be just palliation. In some cases, it would be complete treatment. And in some cases, it would be high palliation. And some patients would be needing salvage surgery for cure.
Absolutely. So thank you for your comments, sir. This patient, because of the extranodal extension that we found, and the fact that he had T4A N3B disease, as you pointed out, based on your decades of experience, would benefit most from adjuvant chemoradiation. In this one slide, because again, we wanted to be brief and just give everyone a little bit of an idea, especially the early practicing oncologists in the audience. The guidelines for adjuvant therapy are guided by two landmark papers, the EOR-TC 22931 and the RTOG 9501. Based on this, there was a pooled analysis, and the pooled analysis indicated the indications for combining these. So this is what the NCCN says, the large text at the bottom. The two indications in red are currently the indications that we use, not just for the larynx, but for most of the head and neck in deciding our adjuvant therapy considerations. Giving those patients adjuvant systemic therapy plus radiation therapy is associated with a higher survival. The other indications, the ones in blue, are the indications for adjuvant radiation therapy alone in most head and neck cancer. Again, not just larynx, but we use these guidelines for decision making. Any panelist wants to comment on their experience and their and a philosophy? Do you differ from NCCN in terms of selecting? And I know guidelines are not just there for they're a template, but you might be doing something different. So share your experience with us.
Dr. Shamit, I want to add one thing, that because whatever the guidelines NCCN has mentioned, they are with the typical situations, but because nowadays that the situation you can see are different in view of the COVID. So we should have also considered some other protocols which are particularly fit in this COVID situations, like we can consider some of the patient for split course accelerated hypofractionated radiotherapy, in which we give some sort of hypofractionated protocols after a specific duration, like 20 gray 5 fraction. After a month again we repeat with 20 gray 5 fraction. It means we have to more consider for palliative regimes and metronomic chemotherapy as well.
So, I would, again, I appreciate all your thoughts, and I'm not the expert in this, but any other panelists in the radiation fraternity would probably want to comment on that. I think we've talked about the fact that conventional fractionation is for the most part, okay, but yes, in resource constrained environment, commuting facility problems, the unique problem that we are facing, COVID, because that is the theme of this cancer conference, treating cancer in the times of COVID, and your comments are very well appreciated in that regard. So I think the bottom line for me as a surgical oncologist, when I go up to you and talk to you in tumor board about a patient and his pathology like this, is to rely on our expertise to give us options as to what could be done in this patient, where we are already short of resources, potentially short of commuting time. Patients can't really stay for as long as they used to be able to. So comments well taken. I think, does anyone want to comment on dose and fractionation in this patient? And again, like I said, we'll take the senior most comments. So maybe Dr. Kaushal can again tell us what his preference would be in the adjuvant setting for this patient.
In the adjuvant setting, we would need a dose of about 60 gray in 6 weeks. And if we are treating by simultaneous integrated boost, the areas which are at low risk, these can get 54 gray. The areas which are at high risk, they can get about 64 gray. And the areas which are moderate risk would get about 60 gray. So 60 gray, 6 weeks, 30 fraction would be a moderate dose if treated by conventional fractionation. If we are treating by IMRT, then we can vary the dose in the high risk areas and the low risk areas so that the tolerance of the patient is better.
Okay, great. Thank you for your comments, sir. And again, just to show you how a laryngectomy patient is, I can see Nitika in the tiles now, and I'm sure she's going to give me a time reminder. But before, so a laryngectomy patient can be rehabilitated quite well, and that is our take home for all of you from a surgeon's perspective, of course.
आवाज में कोई तब्दीली चाहिए, अंगूठा रख के बोलने के बाद कोई प्रॉब्लम नहीं, कोई प्रॉब्लम बिल्कुल आप ना।
So we'll abbreviate this video in the interest of time. We now have about 350 members in our laryngectomy club, and this is something where we typically try to rehabilitate them, just like all of you do in your respective practices. Whether a patient gets multimodality treatment through a combination of various modalities, it behooves us to make sure that a patient gets intra-treatment and post-treatment mitigation of morbidity. Nitika, I think we should skip this case, right? This was our last case. We'll skip it.
Yes,
Yeah, I think.
as far as the time is
I think
concerned,
we
we
are
need to
running now
skip,
short
sir.
of time.
Absolutely.
We have to close the session.
Absolutely. So this was of course the firing line. This was glottis, laser versus radiation, but we'll skip that, and we'll encapsulate our management of laryngeal cancer in the last slide. And this is more philosophical, but I hope that all of you agree with it. And these are my conclusions for a panel that's full of experts, but all of us need to probably advocate this philosophy. So multidisciplinary approach, correct selection of treatment modality, because now we know we can treat a significant majority of these patients, and we also need to obviate toxicity in these patients, and we have to individualize them. The only way we can individualize them is by offering them innovative solutions and discussing them in tumor board. And rehabilitative strategies. So when your initial plan is made, your rehab plan should also already be made so that you can mitigate manifest morbidity. And we know that future developments have the potential to transfer laryngeal cancer management. Did not go too much into it, but there are multiple things, including bioselection and a lot of other trials which are in the pipeline, which can do that. I'll leave you with some pictures of our laryngectomy club. And first and foremost, I want to thank Dr. Deepak and his team. I want to thank our expert panelists and our senior most faculty in the group, Dr. Pramod and Dr. Vivek Kaushal. And of course, the attendees. Hopefully you will have questions and maybe you can get them addressed through Nitika, through Dr. Deepak and his dynamic team. Thank you so much. And again, it's great to be part of this conference again.
Thank you, sir.
Thank you.
Over.
Thank you,
So
Dr.
Dr.
Shamit.
Pramod
Excellent
wanted
discussion.
to.
Thanks, Dr. Shamit and Dr. Arul.
Thank you, sir.
Dr. Shamit is online.
So
Yes,
Dr.
sir.
Pramod wanted
Over
to say something,
yes.
sir.
Yes, sir. Please go ahead.
Dr. Shamit, there are few questions.
Yes, sir.
One is for RAF. Where was your anastomosis, microvascular anastomosis?
So normally, sir, we normally will always have one jugular at least. So we like doing end to side to the internal jugular vein. That's the venous anastomosis. For larynx, we end up using more superior thyroid because the vessel pedicle geometry is better compared to the oral cavity, where we end up using the facial more often. So superior thyroid much more often. And again, depends on the flap. Sometimes the ALT pedicle is very, very thin, so that matches well with the superior thyroid. So it's generally a treatment during the surgery based on the caliber of the vessel and the anticipated vessel pedicle geometry.
What is your experience for the jugular? Oh, sorry, this is jejunum flaps.
So we've only done a few jejunal free flaps, sir. The advantages purported, and I'm trying to be as brief as possible about this. In jejunum, the advantages are that you have secretory mucosa and there is peristalsis innate to the flap. The disadvantages are that you get a very gurgly voice if you use a TEP, and the other problem is we've recently finished 500 free flaps and we did an audit on that. The problem with the jejunal free flap is that you don't have much ischemia time. So by the time we have to explore about 6 to 7% of these patients, as you know, and it's comparable across the world. So if you pick up ischemia in a jejunal flap, there's virtually no time to salvage it because gut does not have much of an ischemia time compared to fasciocutaneous free flap. So our practice for the most part for hypopharyngeal reconstruction in circumferential defects, for patches, we do the pectoralis major like you pointed out. In circumferential, we either use the radial forearm or the anterolateral thigh free flap depending upon the habitus of the patient.
Thanks a lot. It was a wonderful experience. Thank you, Dr. Shamit. And last comment, I wish you a belated birthday. Very happy birthday.
Thank you. Thank you. I think a lot of friends in the group also wished, but again, it's a long time. But today we should wish Dr. Deepak a happy 8th birthday of KrabbyCon. So happy 8th birthday of KrabbyCon.
Thank you.
Yeah, Deepak is great, man.
Happy birthday. So I'll request Dr. Vivek Kaushal sir if he is here for a final word, and then.
Yes, so we have.
Okay, so we have had a great discussion, and the carry home message is that for head and neck cancer, if it is early T1 or T2, then surgery and radiation therapy would give equal cure rate. If it is T3 or more, then every chance should be taken with concomitant chemoradiation. And if it is locally advanced, then triple modality would be needed, either surgery before or surgery after concomitant chemoradiation. And that would lead to the maximum chances of cure. Thank you very much, Dr. Shamit. Great discussion, and everybody enjoyed so much. Very fruitful.
It means a lot.
Dr. Deepak, thanks a lot. Thank
So
you,
we have come to the end of the session, day 2, and we are thankful to the faculty for attending and the faculty who have contributed we had at one time 275 persons attending this conference on virtual platform. Right now, we are having about 97 on virtual platform, which we have created. And right now, I am seeing here only 10 or 11 participants. But this is because everybody has left, and now only I think organizers are left on Zoom's platform. But we still have on this virtual platform 97 about attendance on this link which we had shared. And this was highly attended conference. Day 2, about total of 320 faculty who have attended and 70 faculty who have contributed. And for tomorrow, I request Ravindra and Sunidhi to be on time and start at 9:45, because we have a technical glitch. I had a technical glitch in the at about 5 p.m. today, so I don't want that to repeat tomorrow. Ravindra and Sunidhi.
Sure, sir.
Sure, sir. We'll take care of that, sir. Sure.
Okay. Thank you. Thanks all.
Thank you.
Thank you all the
Thank you.
panelists.
Thanks.
Thank you, Dr. Shamit.